Hello everybody and welcome back to MooseMed. Welcome to MSK II. We're going to be covering a lot of rheumatic diseases, inflammatory diseases, and then we're going to touch on the pharmacology as to how to treat them, the different approaches to treating them, and yeah, just try to have fun along the way. I think something to help keep me motivated with topics like these is just, as physicians, you go in to help heal people, right? To encourage healing, and there's no better way to do that than to know who your enemies are. And by learning all of these different pathologies, these are your enemies, right? These are the ops you're going to be fighting your entire career as a doctor. And then when it comes to the pharmacology, I like to get myself excited about that by picturing them as our weapons, right? These are going to be your tools to tackle these diseases. So anyway, just sharing a little bit about what gets me interested in this stuff, so I hope you guys are too. Let's dive into it. All right, so osteoarthritis, or OA, is often called degenerative joint disease, but it is more than simple wear and tear. Under normal conditions, chondrocytes maintain articular cartilage by balancing the production and breakdown of its extracellular matrix, especially type 2 collagen and proteoglycans. In osteoarthritis, mechanical stress, aging, prior injury, and low-grade inflammation disrupt this balance. Chondrocytes initially attempt to repair the damage, but they eventually produce matrix metalloproteinases and other destructive enzymes. And so basically, they build those up faster than they can rebuild the matrix. And so this causes progressive loss of type 2 collagen and cartilage integrity. Cytokines such as interleukin-1 and TNF also promote the destructive processes, although osteoarthritis is much less inflammatory than rheumatoid arthritis. And we'll get into that distinction later. Primary osteoarthritis usually develops later in life without one specific underlying cause, commonly affecting people in their 50s through 70s. Secondary osteoarthritis occurs when a known problem, such as trauma, congenital joint deformity, obesity-related mechanical stress, or another systemic disease, accelerates cartilage damage at a younger age. So the key concept is that osteoarthritis represents cartilage degradation combined with an inadequate repair response. All right, so the structural changes of osteoarthritis begin with a normally smooth articular surface becoming softened, granular, and rough. As degeneration progresses, fissures and clefts extend into the cartilage, and pieces may break free into the joint space. These loose fragments are called joint mice and can cause intermittent catching or locking. Continued cartilage loss eventually exposes the underlying subchondral bone, and repeated contact and friction polish this exposed bone, producing a smooth ivory-like surface called eburnation. The bone also responds to increased mechanical stress by becoming thickened and sclerotic and by forming marginal osteophytes, commonly called bone spurs. Synovial fluid may be forced through cracks into the subchondral bone, producing subchondral cysts. On an X-ray, cartilage itself is not visible, so cartilage loss is inferred from narrowing of space between the bones. Osteoarthritis classically produces non-uniform joint space narrowing, subchondral sclerosis, cysts, and osteophytes. In the knee image, the arthritic joint has a visibly reduced joint space compared with the normal knee, so reflecting that significant loss of articular cartilage. All right, so osteoarthritis classically causes mechanical joint pain, meaning that pain worsens with activity and improves with rest. Morning stiffness may occur, but it's usually brief, often lasting less than 30 minutes compared with prolonged inflammatory stiffness of rheumatoid arthritis. Patients may also describe stiffness after sitting still, sometimes called the Gelling phenomenon. Examination commonly reveals crepitus, decreased range of motion, and bony enlargement rather than prominent warmth and soft tissue swelling. Weight-bearing joints such as the hips, knees, and lower lumbar spine are frequently affected. In the hands, osteoarthritis commonly involves the distal interphalangeal joints, proximal interphalangeal joints, and the first carpometacarpal joint at the base of the thumb. Osteophytes at the distal interphalangeal joints are called Heberdean nodes, while those at the proximal interphalangeal joints are called Bouchard nodes. Spinal osteophytes can narrow neural foramina and compress nerve roots, producing radicular pain, numbness, and weakness. So true inflammatory ankylosis is not typical of osteoarthritis. But in advanced disease, however, large osteophytes can bridge the joint space and occasionally create a secondary mechanical fusion. All right, so rheumatoid arthritis, or RA, is a systemic autoimmune disease centered on persistent inflammation of the synovium. The process produces non-suppurative proliferative synovitis, okay, meaning that the synovial lining becomes chronically inflamed and enlarged without the pus-producing infection seen in septic arthritis. Activated CD4 positive T cells help coordinate the damage. Th1 cells release interferon gamma, which activates macrophages and synovial cells, while Th17 cells release interleukin-17, recruiting neutrophils and monocytes to the joint. Activated macrophages then produce inflammatory cytokines, especially TNF and interleukin-1, and these cytokines stimulate synovial cells to release proteases that degrade cartilage. They also promote rank L signaling, which activates osteoclasts and produces the characteristic marginal bone erosions of rheumatoid arthritis. B cells and plasma cells within the synovium produce autoantibodies, including rheumatoid factor and antibodies against citrulline proteins. Persistent inflammation transforms the synovium into aggressive tissue that grows across the articular surface, destroying both cartilage and bone. The end result is progressive joint deformity, instability, and in severe late disease, fibrous or bony ankylosis. Rheumatoid factor is important to point out that it's an IgM antibody against IgG antibodies. All right, so rheumatoid arthritis develops through an interaction between genetic susceptibility and environmental triggers. Important genetic associations include particular HLA class II molecules, especially HLA-DRB1 variants, which are efficient at presenting citrulinated peptides to T cells. Citrullination is a post-translational modification in which arginine residues are converted into citrulline, potentially making normal proteins appear foreign to the immune system. Variants in PTPN22 can further impair normal T cell regulation. Smoking is a major modifiable risk factor because it promotes citrinylation in the lungs and is strongly associated with seropositive rheumatoid arthritis. Infections may also create inflammatory environments that encourage citrullination, although rheumatoid arthritis itself is not a joint infection. The most diagnostically useful antibody is anti-CCP, which is one type of anti-citrulinated protein antibody. It is relatively specific for rheumatoid arthritis and can appear before clinical symptoms. Rheumatoid factor is usually an IgM antibody directed against the Fc portion of IgG, although IgA forms can also occur. Rheumatoid factor is common in rheumatoid arthritis, but it's not specific and may appear in other autoimmune diseases, chronic infections, and some healthy adults. Therefore, a patient with symmetric MCP and PIP arthritis, prolonged morning stiffness, and ulnar deviation strongly suggests rheumatoid arthritis, with anti-CCP providing particularly valuable diagnostic support. Okay, so the defining morphologic lesion of rheumatoid arthritis is the pannus. A pannus is a thick, edematous, hyperplastic synovium composed of inflammatory cells, proliferating fibroblasts, new blood vessels, and granulation tissue. Rather than remaining confined to the joint lining, this tissue grows over the articular surface and actively destroys cartilage. Microscopically, the synovium shows marked hyperplasia, dense inflammatory infiltrates, angiogenesis, and neutrophils within the synovial fluid. Osteoclast activation at the junction between the synovium and bone creates marginal erosions. Sorry, my cat just stepped on the keyboard there. So, as cartilage and bone are progressively damaged, the joint may become unstable and deformed, and so healing by scar tissue can then produce fibrous ankylosis, and this may eventually ossify into bony ankylosis, although complete fusion is a late and uncommon outcome. Rheumatoid nodules are another important morphologic finding. They usually occur over pressure points and exterior surfaces, including forearms, elbow, occiput, and lumbosacral regions. Histologically, they contain central fibrinoid necrosis surrounded by palisading histocytes and chronic inflammatory cells resembling a necrotizing granuloma. Nodules are most strongly associated with seropositive and more severe systemic disease. All right, so rheumatoid arthritis may begin with constitutional symptoms such as fatigue, malaise, low-grade fever, and generalized musculoskeletal discomfort before obvious arthritis develops. The typical joint pattern is symmetric inflammation polyarthritis. Affected joints are warm, swollen, tender, and painful, with prominent morning stiffness that commonly lasts longer than an hour and improves with movement. Rheumatoid arthritis particularly favors the metacarpophalangeal and proximal interphalangeal joints, as well as the wrists and metatarsophalangeal joints of the feet. The ankles, elbows, and knees may also be involved, while the distal interphalangeal joints are usually spared. Chronic synovitis damages cartilage, bone, tendons, and ligaments, leading to the characteristic deformities. Ulnar deviation describes movement of the fingers toward the ulna at the MCP joints. A swan neck deformity combines PIP hyperextension with DIP flexion, while a boutonniere deformity combines PIP flexion and DIP hyperextension. Rheumatoid arthritis generally follows a waxing and waning course, with flares separated by periods of lower disease activity. Because rheumatoid arthritis is systemic, patients may also develop rheumatoid nodules, eye inflammation, interstitial lung disease, pleuritis, pericarditis, vasculitis, anemia, and cervical spine instability. Right, so the fastest way to distinguish osteoarthritis from rheumatoid arthritis is to identify whether the presentation is mechanical or inflammatory. Osteoarthritis is a degenerative cartilage disorder in which pain worsens with use and improves with rest. It commonly affects the hips, knees, lumbar spine, distal and proximal interphalangeal joints, and first carpometacarpal joints. Heberden and Bouchard nodes represent osteophytes at the DIP and PIP joints, respectively. And then you got morphologic findings, which include cartilage fissures, joint mice, eburnation, osteophytes, subchondral sclerosis, and cyst formation. Osteoarthritis has no characteristic autoantibody, and true inflammatory joint fusion is unusual. Rheumatoid arthritis, in contrast, is an autoimmune inflammatory synovitis. It produces warm, swollen joints and prolonged morning stiffness that improves with activity. The distribution is usually symmetric and favors the MCP, PIP, and wrist, as well as foot joints, while generally sparing the DIPs. Persistent synovitis produces a pannus, marginal erosions, deformity, and possible fibrous or bony ankylosis. Anti-CCP antibodies are relatively specific for rheumatoid arthritis, whereas rheumatoid factor is common but non-specific. For an exam question, DIP involvement with use-related pain strongly favors osteoarthritis, while symmetric MCP and PIP disease with prolonged morning stiffness strongly favors rheumatoid arthritis. All right, so what was historically called juvenile rheumatoid arthritis is now more accurately termed juvenile idiopathic arthritis, or JIA. It is not simply adult rheumatoid arthritis occurring in a child. It is a group of inflammatory arthritis that begin before age 16 and persist for at least 6 weeks after other causes have been excluded. Adult rheumatoid arthritis commonly presents in the early to middle adulthood as a symmetric polyarthritis involving small joints, particularly the MCP and PIP joints. Rheumatoid factor and anti-CCP may be present, and rheumatoid nodules are more likely in seropositive disease. JIA more commonly presents with oligoarthritis, meaning involvement of 4 or fewer joints during the first 6 months, and large joints such as the knee and ankles are much more affected. However, the exact pattern varies considerably among JIA subtypes. Rheumatoid factor and rheumatoid nodules are absent in most children, although an RF-positive polyarticular subtype resembles adult rheumatoid arthritis. ANA is often positive in oligoarticular JIA and identifies children at increased risk for chronic anterior uveitis, so regular eye screenings are essential even when the child has no ocular symptoms. Adult rheumatoid arthritis and JIA share genetic and immune mechanisms, including HLA and PTPN22 associations and Th1 and Th17 mediated inflammation, but their clinical patterns and laboratory profiles differ. There's a part at the very end that goes really in depth into JIA, so I'm not really going to cover it right now, but at the very end of the video, I'm going to tap back into it. All right, so the seronegative spondyloarthropathies are a family of inflammatory disorders that include ankylosing spondylitis, reactive arthritis, psoriatic arthritis, and arthritis associated with inflammatory bowel disease. The term seronegative indicates that rheumatoid factor is usually absent, but a negative rheumatoid factor alone does not establish the diagnosis. Unlike rheumatoid arthritis, which primarily targets the synovium, these diseases have a strong tendency to inflame enthesis, the site where tendons, ligaments, and joint capsules attach to bones. They also commonly involve the sacroiliac joints and axial skeleton. Patients may therefore present with inflammatory back pain that improves with activity, worsens with rest, and is associated with prolonged morning stiffness. Many of these conditions are associated with HLA-B27, although carrying HLA-B27 is a risk factor rather than a diagnosis. Chronic inflammation at the enthesis can stimulate new bone formation, producing bridging bone and eventually ankylosis. Ankylosing spondylitis primarily causes axial and sacroiliac disease, which reactive arthritis develops after certain GI or genitourinary infections, even though the affected joint itself is sterile. The big exam common buzzword or setup for the patient is, they have sacroiliac inflammation or enthesitis, okay, in a patient who has a negative rheumatoid factor, and then especially when it's accompanied by that HLA-B27. All right, so ankylosing spondylitis and reactive arthritis belong to the seronegative spondyloarthritis family, but their typical triggers and distributions differ. Ankylosing spondylitis primarily affects the sacroiliac joints and axial skeleton. It commonly presents in a younger adult with inflammatory back pain that is worse after rest, improves with activity, and causes prolonged morning stiffness. Inflammation begins at the enthesis and can stimulate new bone formation. Over time, syndesmophytes may bridge adjacent vertebrae, producing the classic bamboo spine appearance and eventually ankylosis. Peripheral joints may also be affected, especially the hips and shoulders. Reactive arthritis, in contrast, develops after an infection located elsewhere in the body, usually genitourinary infection with chlamydia or GI infection with salmonella, shigella, yersinia, or campylobacter. The joint itself is generally sterile. It typically causes an asymmetric oligoarthritis of the lower extremities, often involving the knee, ankles, or feet, and may be accompanied by urethritis or cervicitis, conjunctivitis, or uveitis, and enthesitis. HLA-B27 increases susceptibility and the risk of severe or persistent disease, but it is not required and is not present in every patient. So infectious arthritis occurs when a microorganism enters a joint and produces inflammation that can rapidly destroy articular cartilage. The most common route is hematogenous spread, meaning that organisms travel through the bloodstream and seed the synovium. Infection can also follow direct inoculation from trauma, surgery, and injection or a prosthetic joint. Finally, it may spread directly from nearby cellulitis, an abscess, or osteomyelitis. Suppurative or septic arthritis typically presents as an acutely painful, warm, swollen joint with a major reduction in both active and passive range of motion. It is usually monoarticular and frequently involves a large joint such as the knee or hip, although the shoulder, elbow, and wrist can also be affected. Fever may be absent, especially in older or immunocompromised patients. Because untreated infection can destroy cartilage within days and may lead to sepsis, a hot, painful monoarthritis must be considered infectious until proven otherwise. Urgent arthrocentesis is needed for synovial white blood cell count, gram stain culture, and crystal analysis. Finding crystals does not completely exclude simultaneous infection. Treatment generally requires prompt antimicrobial therapy and drainage or debridement of the infected joint. So, suppurative arthritis. Staph aureus is the most important overall cause of acute bacterial arthritis and should remain the default organism in many exam questions involving older children or adults. In infants, toddlers, and preschool-age children, Kingula-Kinge is also an important modern cause. Haemophilus influenza type B was historically associated with septic arthritis in children younger than 2, but widespread vaccination has made it much less common. It remains a consideration in an unimmunized child. Gonococcal arthritis should be suspected in sexually active adolescents or young adults. Disseminated gonococcal infection may produce a dermatitis tensinovitis, polyarthralgia syndrome, or evolve into a purulent monoarthritis. Recurrent Neisseria infection suggests deficiency of the terminal complement pathway, meaning C5 through C9. Salmonella is classically associated with osteomyelitis in patients with sickle cell disease, although it could also cause septic arthritis. These associations help narrow the differential down, but joint fluid and blood culture are still essential because no demographic clue identifies the organism with certainty. Current pediatric guidance emphasizes empiric coverage for Staph aureus while considering Kingella in children approximately 6 to 48 months old. All right, so Lyme disease is caused by Borrelia burgdorferi and transmitted by Ixodes ticks. Early localized disease primarily involves the skin and classically produces an expanding erythema migrans lesion. Although this rash is sometimes described as a bullseye, it does not always have a central clearing and may simply appear as just an enlarged red patch. Early disseminated infection occurs when the organism spreads beyond the original site, so manifestations may include multiple skin lesions, facial nerve palsy, meningitis, radicular pain, and Lyme carditis, especially atrioventricular block. Patients may experience migratory muscle and joint pain during this period, but objective Lyme arthritis is more characteristically a later manifestation. Lyme arthritis usually develops within 1 to several months and produces obvious swelling of one or fewer large joints, most commonly the knee. The degree of swelling may be dramatic compared with the amount of pain. Episodes can resolve and recur, move between joints, or progress to persistent arthritis if the infection is untreated. The key distinction is that migratory aches may occur during dissemination, but recurrent or persistent large joint swelling represents true Lyme's arthritis. By the way, that double face droop, that symmetrical face droop is pretty iconic to Lyme's because the most commonly affected cranial nerve in Lyme's is cranial nerve 7. All right, and now we're moving on to crystals, but not like the super fun hippy-dippy type with energies and whatnot. We're moving on to monosodium urate crystals, which I don't know if anyone's rocking that for good luck, but there you go. So crystal-induced arthritis occurs when crystalline material accumulates within or around a joint and activates the innate immune system. The two major exam-tested forms are gout, caused by monosodium urate crystals, and pseudogout, more accurately called acute calcium pyrophosphate crystal arthritis. Other deposits include basic calcium phosphate, which may contribute to calcific tendinitis and destructive joint disease. Wear particles from prosthetic joints, including polyethylene, silicone, or methylcrylate, can also be engulfed by macrophages and provoke a foreign body inflammatory response that contributes to implant loosening and bone loss. Crystal arthritis commonly presents as an acutely red, hot, swollen, extremely painful joint and can closely resemble septic arthritis. For that reason, the diagnosis should be established through arthrocentesis whenever infection is a concern. Synovial fluid is examined with compensated polarized light microscopy to identify the crystal's shape and birefringence. Gout produces needle-shaped, negatively birefringent crystals, while calcium pyrophosphate disease usually produces rhomboid or rod-shaped crystals with weak positive birefringence. And I have an example of these on the following slide, so don't worry about it. So the crystal findings are more specific than the patient's age or joint distribution, although neither crystal nor typical presentation completely excludes concurrent infection. All right, so gout develops when monosodium urate crystals deposit in tissues and trigger inflammation. Urate becomes increasingly likely to precipitate when its serum concentration rises above its approximate solubility limit of 6.8 milligrams per deciliter. Most primary gout results from decreased renal urate excretion rather than excessive production. Kidney disease, dehydration, alcohol use, obesity, metabolic syndrome, and medications such as thiazide or loop diuretics can increase this risk. Less commonly, gout results from excessive uric acid production. HGPRT deficiency impairs purine salvage pathways, causing purines to be degraded into uric acid, while rapid cell turnover from leukemia, chemotherapy, or tumor lysis can produce secondary hyperuricemia. Once urate crystals form, macrophages engulf them. Crystal-induced lysosomal damage activates the NLRP3 inflammasome. leading to interleukin-1 beta release and intense neutrophil recruitment. This produces the sudden inflammation of an acute gout attack. Cooler peripheral tissues favor crystallization, helping explain the classic involvement of the first metatarsophalangeal joint. Importantly, hyperuricemia is necessary for crystal formation, but does not guarantee clinical gout, and serum urate can occasionally be normal during an acute gout attack. So that's your diagnostic key for gout there. Their serum urate may be super high, but it's not gout until you stick a needle in that toe and you get your crystals. All right, so monosodium urate crystals are long and needle-shaped. Under compensated polarized light, they demonstrate strong negative birefringence, appearing yellow when parallel to the slow axis of the compensator and blue when perpendicular. Basically, in monkey brain terms, that just means if it's a yellow needle that's parallel to the arrow, it's going to be gout. If it's a blue needle or rhomboid shape that is parallel to the needle, or that is parallel to the arrow of the polarized light, then it's going to be pseudo-gout. I have a comparison on the next slide, but anyway, we're jumping ahead. So acute gout usually causes the sudden onset of severe pain, redness, warmth, and swelling in a single joint. Approximately half of initial attacks involve the first metatarsophalangeal joint, and gout at this location is called podagra. Okay, so gout at your toe, podagra. Even light contact from a bedsheet may be intolerable. Between early attacks, the patient may be completely asymptomatic. Without adequate urate control, attacks can become more frequent and polyarticular. Chronic deposition produces tophi, which are aggregates of urate crystals surrounded by macrophages, foreign body giant cells, and fibrous tissues. Tophi commonly occur around joints. The olecranon, bursa, fingers, toes, and external ear. Chronic tophaceous gout can produce destructive erosions, hyperplastic synovium, and progressive joint deformity. Renal consequences include uric acid nephrolithiasis and urate-related kidney injury. Pyelonephritis is not directly caused by gout, but urinary obstruction from stones can increase the risk of infection. All right, so calcium pyrophosphate deposition disease, or CPPD, becomes increasingly common with age and usually affects adults older than 50. Acute inflammation caused by these crystals was historically called pseudogout. So CPPD may be sporadic, hereditary, or secondary to another condition. Familial disease can involve an autosomal dominant mutation affecting the ANKH pyrophosphate transport protein. Secondary infections include previous joint damage, hyperparathyroidism, hemochromatosis, hypomagnesemia, and other metabolic disorders. Calcium pyrophosphate crystals initially form within articular cartilage, fibrocartilage such as the knee meniscus, and sometimes intervertebral discs. Deposits may then shed into the joint space where they activate the inflammasome and cause an acute inflammatory attack. Radiographs may show chondrocalcinosis, meaning linear calcification within the cartilage, especially in the knee menisci or triangle fibrocartilage of the wrist. On synovial fluid analysis, the crystals are usually rhomboid or rod-shaped and demonstrate weak positive birefringence, although some crystals show little or no visible birefringence. So this weak appearance makes CCP crystals easier to miss than gout crystals. On a vignette, that would just be called positively birefringent is pseudo-gout, whereas negatively is gout. All right, and finally, one more slide to just really knock this out of the park here. So gout and pseudo-gout can both cause acute red, hot, swollen joint. So the most reliable distinction comes from synovial fluid analysis. Gout is caused by those monosodium urate crystals, and these crystals are needle-shaped and strongly negatively birefringent. Gout is associated with hyperuricemia, classically affects the first metatarsophalangeal joint, all right, your toe, and may eventually produce tophi. Pseudogout is caused by calcium pyrophosphate crystals, and these crystals are usually rhomboid or rod-shaped and weakly birefringent, also known as weakly positive birefringent. CPPD generally affects older adults and favors larger joints, particularly the knee and wrist, although the elbow, shoulder, ankle, and MCP joints may also be involved. CPPD is associated with aging, prior joint injury, hyperparathyroidism, hemochromatosis, and hypomagnesemia. Its deposits begin with cartilage or menisci and may create radiographic chondrocalcinosis, like we said, and then under a red compensator, negatively birefringent crystals appear yellow when parallel, whereas positively birefringent CPP crystals appear blue when parallel. Okay, but again, the monkey mode way to think about it is gout is needle negative, while pseudogout is going to be a rhomboid positive. Okay, in either condition, synovial fluid should also be cultured when septic arthritis remains possible. All right, so a ganglion cyst is a benign mucin-filled mass that most commonly occurs around the wrist, especially on the dorsal surface. It may feel firm or fluctuant, but it can change in size and often transilluminates. Despite its name, it's not a true cyst because it lacks an epithelial or synovial lining. Instead, it develops through myxoid or cystic degeneration of connective tissue near a tendon sheath or joint capsule. Most ganglion cysts are painless, although some cause discomfort, weakness, or nerve compression. A synovial cyst, in contrast, is a true synovium-lined structure. It develops when synovium herniates through a joint capsule or when a synovial bursa enlarges in response to excess joint fluid. The classic example is a Baker cyst in the popliteal space behind the knee, commonly associated with knee disorders such as osteoarthritis, rheumatoid arthritis, or a meniscal injury. A Baker cyst may cause posterior knee fullness and restricted movement. If it ruptures, fluid can track into the calf and mimic deep venous thrombosis. The fastest distinction is histologic. A ganglion results from degeneration and has no true lining, whereas a synovial cyst represents herniated or enlarged synovium and retains a synovial lining. All right, so a tenosynovial giant cell tumor is a usually benign neoplasm arising from the synovium, tendon sheaths, and bursa. The localized form, historically called giant cell tumor of the tendon sheath, most often appears as a slow-growing nodule on a finger or hand. The diffuse form typically affects a large joint, especially the knee or hip, and was historically called pigmented villonodular synovitis, or PVNS. Patients may develop pain, swelling, decreased motion, and recurrent bloody joint effusions. Grossly, the diffuse lesion forms red-brown synovial folds, finger-like projections, and nodules. The brown color comes from hemosiderin deposited after repeated hemorrhage. Microscopically, the lesion contains mononuclear tumor cells mixed with hemosiderin-laden macrophages, lipid-filled foamy macrophages, and osteoclast-like multinucleated giant cells. A characteristic translocation involving chromosomes 1 and 2 can create a COL6A3 CSF1 fusion. Overproduction of CSF1, also called macrophage colony stimulating factor, recruits large numbers of non-neoplastic macrophages into the tumor. So the exam clue is a brown synovial lesion containing hemosiderin and giant cells, especially in a large joint. All right, so soft tissue tumors arise from mesenchymal tissues such as fat, muscle, fibrous tissue, nerves, and blood vessels. Benign tumors greatly outnumber sarcomas, while soft tissue sarcomas represent less than 1% of adult malignancies. Most are sporadic, but certain syndromes increase risk. NF1 is associated with malignant peripheral nerve sheath tumors. APC mutations in Garter syndrome are associated with desmoid tumors, and germline TP53 mutations in Li-Fraumeni syndrome predisposed to several sarcomas. So prior radiation and chronic tissue injury can also contribute. The most common benign soft tissue tumor is a lipoma, which is composed of mature adipocytes and usually forms a soft, mobile, painless, well-circumscribed subcutaneous mass on the trunk or extremity. A superficial fatty mass with a homogeneous appearance is generally reassuring. Features that raise concern for sarcoma include a mass larger than 5 centimeters, rapid enlargement, fixation, or location deep to the fascia. A fatty tumor in the retroperitoneum or another body cavity is particularly suspicious for an atypical lipomatous tumor or well-differentiated liposarcoma rather than a routine lipoma. Liposarcomas are malignant adipocytic tumors with several distinct morphologic and molecular subtypes. A well-differentiated liposarcoma contains mature adipocytes with variation in cell size and scattered atypical stromal cells. It characteristically amplifies chromosome region 12q13 to q15, including MDM2 and often CDK4. MDM2 suppresses p53 activity, so these tumors are locally recurrent but generally do not metastasize unless they de-differentiate. De-differentiated liposarcomas contain a well-differentiated component next to an abrupt area of high-grade non-lipogenic sarcoma and therefore has metastatic potential. Myxoid liposarcomas usually arise in the deep soft tissues of a younger adult's thigh. It contains primitive lipogenic cells in its abundant myxoid matrix with delicate branching or chicken wire capillaries. Its characteristic T1216 translocation produces a FUS DDIT3 fusion. Round cell component represents higher grade myxoid disease. Pleomorphic liposarcoma is a high-grade tumor containing markedly atypical cells and pleomorphic lipoblasts with a complex karyotype. So the molecular pattern is therefore central. So MDM2 amplification suggests well-differentiated or de-differentiated disease, while FUS DDIT3 suggests a myxoid liposarcoma. All right, so nodular fasciitis is a benign, rapidly growing proliferation of fibroblasts and myofibroblasts. It usually occurs in young adults and commonly involves the upper extremities, trunk, head, and neck. Some patients report preceding trauma, although trauma is not required. The lesion develops over a period of weeks, is usually smaller than 5 centimeters, and is generally circumscribed. Its rapid growth rate can be alarming and may clinically resemble a sarcoma. Microscopically, the cells are arranged in short, irregular fascicles that resemble fibroblasts growing in tissue culture. The lesion may show a gradient from cellular myxoid area to a more collagenized and fibrous area. Extravasated red blood cells and inflammatory cells may also be present. Mitosis can be numerous, but they are typically more normal rather than atypical. This distinction is crucial because high mitotic activity alone does not establish malignancy. Nodular fasciitis is a clonal process frequently driven by USP6 rearrangement, classically the MYH9 USP6 fusion produced by T1722. Despite being clonal, it is self-limited and may regress or be cured through limited excision. So fibromatosis are fibroblastic proliferations that occupy a clinical space between benign fibrous lesions and true sarcomas. So superficial fibromatoses arise in the fascia of the palms, soles, or penis and are composed of bland fibroblasts arranged in fascicles within abundant collagen. Palmar fibromatosis or Dupuytren contracture creates firm nodules and cords that can progressively flex the fingers, particularly the ring and little fingers. Plantar fibromatosis, also called Lederhose disease or Lederhose disease, produces nodules in the plantar fascia. Penile fibromatosis is called Peyronie disease and may produce painful penile curvature. Deep fibromatosis is also known as a desmoid tumor, and these tumors do not metastasize, but they infiltrate surrounding structures and can recur locally. Sporadic desmoid tumors commonly contain CTNNB1 mutations, while intra-abdominal desmoid associated with familial adenomatous polyposis or Gardner syndrome result from APC mutations. Both abnormalities activate the WNT pathway and cause nuclear accumulation of beta-catenin. So the central exam distinction is that a desmoid tumor may behave aggressively at its original location while having no metastatic potential. And here on our images here, you see that plantar fibromatosis there on the feet, and then in the intestines there, you see that desmoid tumor. Pretty gnarly. All right, so rhabdomyosarcoma. All right, so rhabdomyosarcoma is a malignant tumor showing skeletal muscle differentiation, although it does not have to arise within skeletal muscle. Embryonal rhabdosarcoma typically affects younger children and commonly occurs in the head and neck or genitourinary tract. So it contains primitive round or spindle cells at different stages of muscle differentiation. More differentiated rhabdomyoblasts may have abundant eosinophilic cytoplasm and visible cross striations. Sarcoma botryoides is an embryonal variant that grows beneath a mucosal surface and forms a grape-like polypoid mass, classically in the vagina of a young child or in the bladder. Alveolar rhabdomyosarcoma more often affects older children and adolescents, frequently in the extremity, so fibrosepta divide discohesive tumor cells into clusters that resemble pulmonary alveoli. Most true alveolar tumors contain a PAX3 FOXO1 or a PAX7 FOXO1 fusion from T213 or T113, and fusion positively is associated with a more aggressive behavior. Pleomorphic rhabdomyosarcoma is a rare adult tumor composed of bizarre eosinophilic cells. So rhabdomyosarcomas express skeletal muscle markers such as desmin, myogenin, and MyoD1. All right, so leiomyoma is a benign smooth muscle tumor. The uterus is the most common site where these tumors are often called fibroids and most frequently become clinically apparent during the reproductive years. Their growth is hormonally responsive, so they may enlarge during pregnancy and often regress after menopause. Depending on whether they are submucosal, intramural, or subserosal, uterine leiomyomas can cause abnormal bleeding, pelvic pressure, infertility, or no symptoms at all. Cutaneous leiomyomas arise from erector pili muscles and may be painful, especially when exposed to cold or pressure. Grossly, a leiomyoma is a well-circumscribed, firm, tan white, and has characteristic whorled-cut surface. Microscopically, it contains intersecting fascicles of uniform spindle cells with eosinophilic cytoplasm and elongated, blunt-ended cigar-shaped nuclei. A typical leiomyoma has minimal atypia, few mitosis, and no tumor cell necrosis. Loss of fumarate hydratase is not a feature of every leiomyoma. Instead, multiple cutaneous leiomyomas or unusually early uterine leiomyomas may suggest hereditary leiomyomatosis and renal cell cancer syndrome caused by germline FH mutation. All right, so leiomyoma versus leiomyosarcoma. So a leiomyoma and leiomyosarcoma both show smooth muscle differentiation, but their behavior and morphology are very different. So a leiomyoma is a well-circumscribed and composed of uniform smooth muscle cells with minimal atypia, few mitotic figures, and no coagulative tumor cell necrosis. Leiomyosarcoma is a malignant and often infiltrative with significant nuclear atypia, increased mitotic activity, and tumor cell necrosis. These three histologic findings, atypia, mitosis, and necrosis, are particularly important when evaluating a uterine smooth muscle tumor. Leiomyosarcoma usually affects middle-aged or older adults and may arise in the uterus, retroperitoneum, deep soft tissues of an extremity, or the smooth muscle of a large blood vessel. It tends to spread hematogenously, particularly to the lungs and liver. Importantly, uterine leiomyosarcomas usually arise independently rather than through malignant transformation of a pre-existing leiomyoma. Both benign and malignant smooth muscle tumors may express smooth muscle actin, desmin, and H-caldesmin. So immunohistochemistry confirms the lineage, but does not by itself determine malignancy. The fastest discriminators favoring leiomyosarcoma are infiltration, marked atypia, frequent mitosis, and coagulative tumor necrosis. All right, so a synovial sarcoma, despite its name, does not arise from the synovium and does not necessarily occur inside a joint. It is a malignant soft tissue tumor that most often affects adolescents and young adults and commonly develops in deep tissues of the lower extremity near a large joint, especially around the knee. Patients may notice a slowly enlarging and sometimes painful mass. The defining molecular abnormality is TX18, which fuses to SS18 on chromosome 18 with an SSX gene on the X chromosome. This fusion is highly characteristic and can confirm the diagnosis. Histologically, the monophasic form is composed mainly of uniform spindle cells arranged in dense fascicles. The biphasic form contains both spindle cells and gland-like epithelial structures. Because of the epithelial component, synovial sarcoma can express cytokeratins and epithelial membrane antigen in addition to TLE1. Some tumors also contain calcification. Synovial sarcoma can recur after treatment and metastasize, most commonly to the lungs, sometimes many years after the original diagnosis. So the key exam pattern is a young adult with a deep lower extremity mass and an SS18 SSX fusion from TX18. So an undifferentiated pleomorphic sarcoma, previously called malignant fibrous histocytoma, is a high-grade malignant mesenchymal tumor with no specific line of differentiation that can be identified. So it usually affects middle-aged or older adults and commonly arises in the deep soft tissue of an extremity, especially the thigh. Patients often present with rapidly enlarging painless mass. Microscopically, the tumor contains highly pleomorphic spindles and giant cells with dramatic variation in cellular size and shape. The nuclei are hyperchromatic and bizarre. Mitotic activity is high. Atypical mitoses are common, and areas of tumor necrosis may be extensive. The tumor typically has a complex karyotype rather than one defining translocation. So the word undifferentiated is important because this is a diagnosis of exclusion. Before applying the diagnosis, pathologists must use morphology, immunohistochemistry, and molecular testing to exclude melanoma, carcinoma, lymphoma, and more specific sarcoma lineages such as skeletal muscle, smooth muscle, adipocytic, or vascular differentiation. Many tumors once called malignant fibrous histocytoma have now been reclassified. So the remaining true undifferentiated pleomorphic sarcomas are aggressive and can recur locally or metastasize hematogenously, especially to the lungs. All right, so this is basically just like a quick rapid review of all the soft tissue sarcomas that we covered, just so you can kind of organize your thinking. So a grape-like vaginal mass in a young child is sarcoma botryoides, a variant of embryonal rhabdomyosarcoma. In an older child or adolescent, an alveolar pattern combined with PAX3 FOXO1 or PAX7 FOXO1 fusion indicates alveolar rhabdomyosarcoma. A well-circumscribed tumor containing bland intersecting fascicles of smooth muscle cells is a leiomyoma, while infiltration, marked atopia, frequent mitosis, and tumor cell necrosis favors leiomyosarcoma. A young adult with a deep lower extremity mass in TX18 producing an SS18 SSX fusion has synovial sarcoma. An older adult with a high-grade pleomorphic sarcoma that lacks identifiable differentiation after extensive testing has undifferentiated pleomorphic sarcoma. And then finally, a locally infiltrative fibroblastic mass with a CTNNB1 or APC mutation suggests a desmoid tumor. Desmoids can recur and damage adjacent structures, but they do not metastasize. The overall strategy is to combine age, location, morphology, immunophenotype, and characteristic molecular alteration rather than relying on any one clue alone. All right, and now we just have a rapid review summary. I kind of sprinkled these in throughout the lecture, so these are just going to be little benchmarks to just kind of summarize, roughly 30 slides at a time. So this summary connects the highest yield clues from the arthritis and soft tissue sections. Pain that worsens with use, brief stiffness, and DIP osteophyte suggests osteoarthritis. Prolonged morning stiffness with symmetric MCP and PIP inflammation suggests rheumatoid arthritis, and anti-CCP is the most specific commonly tested antibody. Sacroiliitis, enthesitis, and negative rheumatoid factors suggest a seronegative spondyloarthropathy. An acutely hot, swollen joint must be treated as septic arthritis until proven otherwise and requires arthrocentesis. In sickle cell disease, salmonella is classically associated with osteomyelitis. It can cause septic arthritis, but Staph aureus remains an important overall consideration. Needle-shaped, negatively birefringent crystals indicate gout, while rhomboid weakly positive birefringent crystals indicate CPPD or pseudogout. A wrist cyst without a true cellular lining is a ganglion cyst, whereas a synovium-lined popliteal cyst is a Baker cyst. Okay. That's the one specifically on the knee, but anyway. Brown villus synovium containing hemosiderin suggests diffuse tenosynovial giant cell tumor. A deep fatty tumor with MDM2 amplification suggests atypical lipomatous tumor or well-differentiated liposarcoma. And then finally, a small, rapidly growing mass with USP6 rearrangement strongly favors benign nodular fasciitis rather than a sarcoma. So bone tumor classification. So bone tumors can be classified according to the tissue or matrix they produce. Hematopoietic lesions include multiple myeloma and primary bone lymphoma. Cartilage-forming tumors produce a chondroid matrix, while bone-forming tumors produce osteoids. Additional categories include tumors with uncertain differentiation and notochordal tumors such as a chondroma. In adults, metastases and multiple myeloma are far more common than most primary malignant bone tumors. Bone lesions may be discovered incidentally, but they may also cause progressive pain, swelling, a palpable mass, pathogenic fracture, or compression of nearby nerves and vessels. The most efficient diagnostic approach begins before reviewing the histology. So first determine the patient's age, because different tumor clusters in different age groups. So then next determine whether the lesion involves the epiphysis, metaphysis, or diaphysis, and whether it is centered in the medulla, cortex, or bone surface. Then assess the radiographic margin, periosteal reaction, cortical destruction, and type of matrix. A narrow, well-defined border generally suggests slower growth, while a permeative border, cortical breakthrough, or soft tissue mass suggests aggressive behavior. Age and anatomic location often narrow the differential dramatically. That's a word now. Dramatically. Oh my gosh. So the location of a lesion within a long bone is one of the fastest ways to narrow down the differential. So epiphyseal lesions are relatively uncommon. Chondroblastoma classically affects the epiphysis of an adolescent or young adult whose growth plate may still be open. Giant cell tumor also favors the epiphysis, but usually occurs after skeletal maturity and often extends to the subarticular bone. Clear cell chondrosarcoma is a rare epiphyseal malignancy in adults. Metaphyseal lesions include osteosarcoma, which commonly develops around the knee, as well as osteochondroma, aneurysmal bone cyst, non-ossifying fibroma, and fibrous cortical defect. Endochondromas are typically centered in the medullary cavity and may be metaphyseal or metadiaphyseal. Ewing sarcoma classically favors the diaphysis of a long bone, although it can also involve the pelvis. Age remains essential here, so a destructive diaphyseal lesion is in a child suggests Ewing sarcoma, while a new destructive lesion in an older adult should raise concern for metastasis, myeloma, lymphoma, or chondrosarcoma. These lesions are strong exam clues, but they are tendencies rather than absolute rules. All right, so osteoid osteoma and osteoblastoma are benign tumors that produce woven bone but differ in size, location, and symptoms. Osteoid osteoma contains a small nidus measuring less than 2 centimeters, usually within the cortex of a long bone. It classically causes severe nocturnal pain that improves dramatically with aspirin or another NSAID because the lesion produces high levels of prostaglandins. Prominent reactive sclerosis surrounds the nidus. Osteoblastoma is larger than 2 centimeters, commonly involves the posterior element of the spine, and causes pain that is less reliably relieved by NSAIDs. It usually produces less surrounding reactive sclerosis. So osteosarcoma is a malignant bone-forming tumor with a peak in adolescence and a second peak in older adults, often in association with Paget's disease, prior radiation, or other bone abnormalities. It most commonly arises in the metaphysis around the knee. Imaging may show a destructive mixed lytic and blastic mass, a sunburst periosteal reaction, or a Codman triangle. So the diagnostic microscopic feature is a malignant tumor cells directly producing irregular lace-like osteoid. And then osteosarcoma commonly spreads hematogenously to the lungs. All right, so conventional osteosarcoma usually has a highly complex genome rather than one defining translocation. Many abnormalities converge on the RB and P53 tumor suppressor pathway. RB normally restrains progression from the G1 phase to the S phase of the cell cycle, so loss of RB therefore allows uncontrolled entry into DNA synthesis, explaining why patients with hereditary retinoblastoma have an increased risk of osteosarcoma. TP53 normally responds to DNA damage by pausing the cell cycle, promoting repair, or inducing apoptosis. So germline TP53 mutations in Lee-Fraumeni syndrome also increase osteosarcoma risk. Inactivation of CDKN2A disrupts the production of P16 and P14, weakening both RB and P53-mediated control. MDM2 overexpression suppresses P53, while CDK4 overexpression phosphorylates and inactivates RB. The shared result is a loss of cell cycle checkpoints and survival of genetically damaged osteoblast lineage cells. So these abnormalities explain the tumor's marked chromosomal instability and pleomorphism. The main exam concept is not one single mutation, but simultaneous disruption of RB and P53 regulatory networks, followed by the malignant osteoid production. So cartilage-forming tumors range from common benign lesions to malignant chondrosarcoma. So osteochondroma is a cartilage-capped bony projection arising from the bony surface, usually near the metaphysis. A chondroma is comprised of benign hyaline cartilage. When it lies within the medullary cavity, it's just called an enchondroma, there you go. And when it arises on the surface, it may be called a periosteal or juxtacortical chondroma. Chondroblastoma is an epiphyseal tumor of adolescents or young adults. Chondromyxoid fibroma is a rare eccentric metaphyseal lesion that usually affects younger patients. Chondrosarcoma is malignant and more often affects older adults, particularly in the pelvis, shoulder girdle, ribs, and proximal long bones. Cartilage matrix frequently produces rings and arcs, stippled or popcorn-like calcification on imaging. When evaluating a cartilage tumor, begin with patient's age and determine whether the tumor is medullary or surface-based. Then assess its skeletal distribution and look for aggressive features such as persistent pain, growth after skeletal maturity, cortical destruction, endosteal scalloping, or a soft tissue mass. So histologic atypia alone may be subtle, so radiologic and clinical behavior here are essential. All right, so an osteochondroma, also called a cartilage-capped exostosis, is one of the most common benign bone tumors. It usually presents during childhood, adolescence, or early adulthood and arises near the metaphysis of a long bone, especially around the knee. The projection may be pedunculated or broad-based and usually points away from the nearby joint. Its defining radiographic features is continuity of both the cortex and the medullary cavity with the underlying parent bone. The surface is covered by cartilage cap that resembles a disorganized growth plate and undergoes endochondral ossification. Most lesions stop enlarging when skeletal growth is complete. Osteochondromas are frequently asymptomatic, but they may cause a visible mass, mechanical irritation, deformity, fracture, or compression of nearby nerve or vessel. New pain or enlargement after skeletal maturity is concerning for secondary chondrosarcoma, particularly when imaging shows a thickened cartilage cap or destruction of adjacent structures. A solitary lesion has a low risk of malignant transformation, while the risk is higher in patients with multiple hereditary osteochondromas. So the key identifying feature remains cortical and medullary continuity with the parent bone. So multiple hereditary exostoses, now often called hereditary multiple osteochondromas, is an autosomal dominant disorder in which numerous osteochondromas develop during childhood. It is caused by a loss-of-function mutation in EXT1 or EXT2, and these genes encode proteins that work together to synthesize heparin sulfate chains, which help regulate the distribution of signaling molecules through the growth plate. Defective heparin sulfate disrupts pathways involved in normal chondrocyte proliferation and differentiation, including Indian hedgehog signaling, allowing cartilage-capped outgrowths to form near growth plates. Patients may develop limb length discrepancies, angular deformities, short stature, restricted joint motion, or compression of nerves and blood vessels. EXT1 associated disease often produces a greater lesion burden than EXT2 associated disease. So the osteochondromas usually stop growing at skeletal maturity, so renewed growth or pain in an adult raises that concern for a secondary peripheral chondrosarcoma. The estimated lifetime risk of malignant transformation is low, but meaningful, approximately 2 to 10%, and is the greatest in lesions of the pelvis, shoulder girdle, and proximal long bone. So a chondroma is a benign tumor composed of mature hyaline cartilage. An enchondroma is located within the medullary cavity, while a periosteal or juxtacortical chondroma develops on the bone surface. Solitary enchondromas commonly occur in adults and frequently involve the small bones of the hands and feet. They are often incidental, but may weaken the bone and cause pathologic fracture. Grossly, the lesion is a well-circumscribed gray-blue translucent cartilage nodule. Imaging may show rings and arcs calcifications without aggressive cortical destruction. Ollier disease consists of multiple, often asymmetrical distributed enchondromas. Maffucci syndrome combines multiple enchondromas with vascular lesions, classically spindle cell hemangiomas. Both are non-hereditary mosaic disorders commonly associated with post-zygotic IDH1 or IDH2 mutations. Mutant IDH produces the oncometabolite 2-hydroxyglutarate, which alters DNA and histone methylation and disrupts normal cellular differentiation. So both syndromes carry an increased risk of chondrosarcoma, which additional malignancy risks, particularly in Maffucci syndrome. Increased cellularity or mild atypia can occur in syndromic enchondromas, so malignant transformation is determined using symptoms, growth, imaging, and destructive barrier rather than cytology alone. So a chondrosarcoma is a malignant cartilage-forming tumor with several major forms. Conventional chondrosarcoma may be central, meaning it develops within the bone, or peripheral, meaning it develops along the bone's outer surface. Additional forms include clear cell, dedifferentiated, and mesenchymal chondrosarcoma. Patient demographics help distinguish these categories, so conventional chondrosarcoma occurs most often after the age of 40 and is more common in males. Clear cell and mesenchymal chondrosarcomas may appear earlier, including during the teenage years or young adulthood. Location is another important clue. Chondrosarcoma tends to involve the axial skeleton, particularly the pelvis, shoulder region, and ribs. Distal portions of the extremities are rarely affected. Clear cell chondrosarcoma has more specific distribution because it favors the epiphysis or end portion of a long bone. And so the main approach is to combine the patient's age with whether the tumor is central or peripheral and whether it involves the axial skeleton or the epiphysis of a long bone. So conventional chondrosarcoma grossly forms a gray-white translucent nodules that resemble hyaline cartilage. Although this cartilage-like appearance may resemble a benign chondroma, the malignant lesion shows increased cellularity, cellular atypia, mitotic activity, and areas of necrosis. So these features indicate that the cartilage-producing cells are proliferating abnormally and that the portions of the tumor may be outgrowing their blood supply. So the other forms have distinct morphological patterns. So dedifferentiated chondrosarcoma contains two sharply differentiated areas, a low-grade cartilaginous tumor located beside a high-grade component that no longer appears cartilaginous. Clear cell chondrosarcoma is named for tumor cells containing abundant clear cytoplasm. Mesenchymal chondrosarcoma has a biphasic appearance with recognizable islands of hyaline cartilage surrounded by sheets of small round cells. The fastest way to organize these forms is by their defining appearances. Conventional resembles abnormal hyaline cartilage. Dedifferentiated combines low and high grade components. Clear cell contains clear cytoplasm, and mesenchymal combines cartilage islands with small round cells. All right, so a giant cell tumor of bone usually affects skeletally mature adults in their 20s through 40s. It characteristically arises in the epiphysis of a long bone and commonly develops around the knee. The combination of age and location is a major diagnostic clue. So grossly, the lesion can expand through and destroy the cortex, leaving only a thin shell of reactive bone around the tumor. Microscopically, the true neoplastic population consists of relatively uniform mononuclear cells, and these tumor cells are mixed with numerous reactive multinucleated osteoclast-like giant cells that are distributed throughout the lesion. The mononuclear cells cells express rank L, which promote the formation and activity of the reactive osteoclast-like giant cells. So this explains the tumor's ability to resorb bone and damage the cortex. So giant cell tumor is classified as benign, but its behavior can be unusual because it may metastasize to the lungs. These pulmonary metastases are rarely fatal, but the high yield pattern is an epiphyseal lesion in a skeletally mature patient containing evenly distributed osteoclast-like giant cells. All right, so an aneurysmal bone cyst most commonly occurs during the first 2 decades of life. It typically involves the metaphysis of a long bone, although it may also develop in a posterior vertebral column. Patients may present with pain and swelling as the lesion expands. If it develops near a nerve, the expanding mass may also produce symptoms from nerve compression. The defining morphological feature is the presence of a large blood-filled space. So these spaces are separated by fibrous septa rather than true blood vessel walls, so they lack a true endothelial lining. The fibrous septa contain fibroblasts, multinucleated giant cells, and areas of woven bone. A densely calcified matrix within these septa may produce the appearance described as blue bone. Despite the word aneurysmal, the lesion is not a vascular aneurysm. The name reflects its expanded blood-filled appearance, so the most important exam clue is therefore a young patient with a metaphyseal or posterior vertebral lesion composed of blood-filled spaces separated by a giant cell containing fibrous septa. All right, Ewing's sarcoma is a malignant bone tumor that predominantly affects children and adolescents, with approximately 80% of cases occurring before the age of 20. It is more common in males, occurs most frequently in white patients, and is rare in Black and Asian patients. Within a long bone, Ewing's sarcoma classically involves the diaphysis or shaft. Common sites include the femur and flat bone of the pelvis. Patients usually present with painful, progressively enlarging masses. Because the tumor weakens the involved bone, it may also lead to pathologic fracture. Microscopically, Ewing sarcoma is composed of small, round blue cells. Homer-right rosettes may be present. Mitotic figures may be relatively few, and geographic areas of necrosis can occur. The defining molecular abnormality is T1122, which fuses to the EWS gene on chromosome 22 with FLI1. The high-yield diagnostic combination is a pediatric diaphyseal tumor composed of small round blue cells and containing the EWS FL1 fusion. All right, so osteosarcoma and Ewing sarcoma both commonly affect patients younger than 20, so their location and morphology are the fastest way to separate them. Osteosarcoma usually arises in the metaphysis of a long bone, especially around the knee. It commonly appears as a mixed lytic and blastic lesion and may lift the periosteum away from the cortex, producing a Codman's triangle. Its defining microscopic features is malignant osteoid produced directly by the tumor cells. Osteosarcoma is also associated with abnormalities affecting the RB and TP53 pathway. Ewing sarcoma, in contrast, usually develops in the diaphysis of the long bone and commonly affects the femur or pelvis. It is composed of small round blue cells, and Homer-right rosettes may be seen. It characteristically has the molecular abnormality of T1122, producing an EWS FL1 fusion. The simplest exam distinction is therefore location plus histology. Metaphyseal malignant osteoid indicates osteosarcoma, whereas a diaphyseal small round blue cell tumor with EWS FLI1 indicates Ewing sarcoma. Plasmacytoma and multiple myeloma are both neoplasms of plasma cells, but they differ primarily in the extent of disease. A plasmacytoma is localized and produces a single solitary mass of neoplastic plasma cells. Multiple myeloma is a diffuse process in which neoplastic plasma cells infiltrate the bone marrow and produce multifocal skeletal disease. In both conditions, the tumor cells retain recognizable plasma cell morphology. The nucleus is usually located eccentrically rather than at the center of the cell. So the chromatin forms a clock face pattern, meaning that dense areas of chromatin are arranged around the edge of the nucleus. A clear area may also be visible next to the nucleus, producing perinuclear clearing. So these morphologic findings identify the cells as plasma cells, but the overall distribution distinguishes the two diseases. So a solitary plasma cell lesion is classified as a plasmacytoma, whereas a diffuse marrow infiltration with multiple skeletal sites is classified as a multiple myeloma. The fastest discriminator is therefore localized disease versus diffuse multifocal marrow disease. All right, so in adults, the most common primary tumors that metastasize to bone arise from the prostate, breast, kidney, and lung. Together, these cancers account for approximately 75% of adult bone metastases. Pediatric tumors that may spread to bone include neuroblastoma, Wilms tumor, osteosarcoma, Ewing sarcoma, and rhabdomyosarcoma. Metastatic tumors frequently involve the axial skeleton, meaning the central portion of the skeleton rather than the distal extremities. As tumor deposits replace or disrupt normal bone, they weaken its structure and may cause a pathologic fracture. Tumor-derived products can also alter bone remodeling by increasing rank L signaling and osteoclast activity. Increased osteoclast activity promotes bone resorption and contributes to skeletal destruction. While evaluating a suspected metastatic bone lesion, the patient's age helps narrow the likely primary tumor. In adults, think first of prostate, breast, kidney, or lung cancer, and in children, consider neuroblastoma, Wilms tumor, and major pediatric sarcomas listed on this slide. All right, so bone metastases can be described as osteolytic or osteoblastic based on how they affect bone. Osteolytic metastases promote bone destruction. As normal bone is removed, the affected area becomes structurally weaker and the risk of pathologic fracture increases. Osteolytic lesions are commonly associated with kidney cancer, lung cancer, and GI cancers. Osteoblastic metastases have the opposite radiographic pattern because they stimulate the formation of new bone. So prostate cancer is the classic primary malignancy associated with osteoblastic metastases. Some metastatic lesions may also show a mixed pattern containing both destructive and bone-forming areas, but the classic exam association remains pretty straightforward. So renal and lung cancer metastases are generally considered lytic, while prostate cancer metastases are generally considered blastic. The terminology describes the dominant response of bone surrounding the metastatic tumor. So osteolytic, right, bone is being destroyed. Osteoblastic means bone production is being stimulated. All right, so fibrous cortical defects and non-ossifying fibromas represent the same basic process, with the name determined primarily by the lesion size. So these lesions are extremely common in children older than 2 and are seen in approximately 30 to 50% of the population. They usually arise in the metaphysis of a long bone, with distal, femur, and proximal tibia being common sites. A fibrous cortical defect is basically just the smaller form. So it is confined to the cortex and usually measured approximately half a centimeter. A non-ossifying fibroma is larger and may reach 5 to 6 centimeters. Microscopically, both lesions contain fibroblasts arranged in a storiform pattern, meaning that the cells form interlacing bundles resembling the spokes of a wheel. Macrophages are also present, so the crucial point is that these are not two unrelated diseases. They represent a spectrum of the same lesion. So a small cortical focus is called a fibrous cortical defect, while a larger lesion extending more substantially through the bone is called a non-ossifying fibroma. All right, so fibrous dysplasia is a developmental arrest of normal bone maturation. So the components required to form bone are present, but they remain immature and are poorly organized. Instead of forming fully mature, normally structured bone, the affected area contains disorganized developing tissue. So fibrous dysplasia usually becomes apparent during early adolescence and affects males and females equally. Common locations include the femur, tibia, ribs, mandible, clavarium, and humerus, so the disease may involve either the appendicular or craniofacial skeleton. The condition is divided into monostotic and polyostotic forms. So monostotic disease affects a single bone, while polyostotic disease affects multiple bones. This distinction describes the extent of skeletal involvement and becomes important when connecting fibrous dysplasia with its associated syndromes. The key concept is that fibrous dysplasia is not simply excess fibrous tissue. It represents abnormal bone development in which normal skeletal components fail to mature and organize correctly. All right, so fibrous dysplasia can occur as part of two important syndromes. So Mazabrod syndrome combines fibrous dysplasia with soft tissue myxomas. And then in a clinical vignette, the simultaneous presence of abnormal bone lesions and myxoid soft tissue masses should therefore suggest Mazabrod syndrome. McCune-Albright syndrome combines polyostotic fibrous dysplasia with cafe au lait macules and endocrine abnormalities. So the endocrine component represents excessive hormonal activity, and precocious puberty may be one of its clinical manifestations. So the distribution of skeletal disease is important because McCune-Albright syndrome involves multiple bones rather than a single isolated lesion. The most useful recognition pattern is the triad of polyostotic fibrous dysplasia, cafe au lait pigmentation, and endocrine hyperfunction. If fibrous dysplasia is instead associated with soft tissue myxomas, the appropriate diagnosis is Mazabrod syndrome. These syndromes demonstrate that fibrous dysplasia can appear either as an isolated skeletal process or as a component of a broader disorder involving soft tissue, pigmentation, or endocrine function. All right, so fibrous dysplasia is caused by a gain-of-function mutation of the GNAS1. This mutation produces constitutive activation of GS protein, meaning that the signaling pathway remains active when it should be normally regulated. So this results in increased cellular proliferation and disruption of normal osteoblast differentiation. Fibrous dysplasia is a post-zygotic mosaic disorder, so the timing of the mutation determines the extent of the disease. A mutation occurring during embryogenesis affects more developing cells and produces polyostotic disease, while a mutation occurring after skeletal formation produces more limited monoostotic disease. Grossly, the lesion is intramedullary and has a gritty texture. Microscopically, it contains curved trabeculae of woven bone within a fibrous background. Osteoblastic rimming is minimal, and irregular trabeculae create a pattern resembling Chinese characters. And then you got cartilage nodules, cystic degeneration, and hemorrhage that can also occur. Monoostotic disease is often asymptomatic, although pain or fracture can be possible. Polyostotic disease can produce deformities and fracture. Transformation into a sarcoma is possible, but rare. So here's a quick little cheat sheet about bone tumor location. So bone tumor questions become easier when location is combined with tumor's defining feature. So a metaphyseal lesion around the knee, that produces malignant osteoid indicates osteosarcoma. A diaphyseal lesion in a child composed of small round blue cells indicates Ewing sarcoma. An epiphyseal lesion around the knee containing giant cells indicate a giant cell tumor. A lesion larger than 2 centimeters in the posterior spine suggests osteoblastoma, while a femoral or tibial lesion causing nocturnal pain relieved by an NSAID suggests osteoid osteoma. A metaphyseal exostosis whose bone marrow cavity is continuous with that of the parent bone is an osteochondroma. A small hyaline cartilage lesion in the hand or feet is a chondroma, whereas a cartilage-forming tumor in the axial skeleton of an older adult suggests a chondrosarcoma. And then finally, a blood-filled metaphyseal lesion in a child indicates an aneurysmal bone cyst. So the strategy is to identify the patient's age, the lesion position within the bone, and the defining matrix and microscopic findings. Here's another one of our rapid recognition summary reviews here. So the slide reviews the fastest associations for a major soft tissue and bone lesion. Okay, so a desmoid tumor is locally infiltrative but does not metastasize. A grape-like vaginal mass in a child indicates embryonal rhabdomyosarcoma, while an alveolar pattern with FOXO1 fusion indicates alveolar rhabdomyosarcoma. A smooth muscle tumor with necrosis and increased mitosis favors leiomyosarcoma. A lower extremity tumor with TX18 indicates synovial sarcoma. Nocturnal pain relieved by aspirin suggests osteoid osteoma. A metaphyseal lesion producing malignant osteoid indicates osteosarcoma, while cartilage capped projection continuous with patient's marrow indicates osteochondroma. An epiphyseal lesion containing reactive osteoclast suggests a giant cell tumor. A diaphyseal small round cell tumor with EWS-FLI1 fusion indicates an Ewing sarcoma. Prostate cancer metastatic to bone is characteristically osteoblastic. Finally, a GNAS mutation combined with curvilinear trabeculae resembling Chinese characters indicates fibrous dysplasia. And so these pairings connect clinical presentation, location, morphology, and molecular finding. All right, so bone contains organic and inorganic components that work together to provide structure and strength. So osteoblasts form new bone by producing osteoid. They also regulate osteoclasts through rank L and osteoprotegrin. Once an osteoblast becomes surrounded by the matrix it produced, it develops into an osteocyte. Osteocytes are mature bone cells located within lacunae. They maintain the surrounding matrix and respond to mechanical stress. Osteoclasts are multinucleated bone-resorbing cells derived from monocytes and macrophage precursors. Their formation and survival depends on rank signaling. Osteoid is the unmineralized protein framework of bone. So the inorganic component is primarily calcium hydroxyapatite, which mineralizes the framework. Bone contains approximately 99% of the body's calcium, 85% of its phosphorus, and approximately 65% of its sodium and magnesium stores. So the central concept is that osteoid provides the flexible protein framework, while hydroxyapatite supplies mineral strength. Normal bone, therefore, depends on both its cellular components and its proper combination of organic matrix and inorganic materials. Vitamin D metabolism begins in the skin, where ultraviolet light converts 7-dehydrocholesterol into cholecalciferol. Approximately 90% of vitamin D comes from this UV-dependent process, while approximately 10% comes from the diet. Cholecalciferol then travels to the liver, where it is converted into 25-hydroxyvitamin D. In the kidney, the enzyme 1-alpha-hydroxylase converts this molecule into active 1,25-dihydroxyvitamin D. So low calcium stimulates parathyroid hormone, which activates renal 1-alpha-hydroxylase. Low phosphate also stimulates this enzyme. And active vitamin D increases the intestinal absorption of both calcium and phosphate and increases their renal absorption, reabsorption that is. In bone, vitamin D stimulates osteoblasts to produce osteocalcin, which promotes calcium deposits and mineralization. Vitamin D also works with parathyroid hormone to maintain plasma calcium. During hypocalcemia, vitamin D and PTH increase bone resorption to make calcium available. When calcium is adequate, vitamin D supports mineralization. So the high yield concept here is that vitamin D increases the availability of both calcium and phosphate. All right, so parathyroid hormone, or PTH, is secreted in response to hypocalcemia. So its major purpose is to restore serum calcium concentration. In the kidney, parathyroid hormone activates 1-alpha-hydroxylase, increasing the production of active vitamin D. Active vitamin D then supports intestinal calcium absorption. PTH also increases renal calcium reabsorption, meaning that less calcium is lost to urine. In bone, PTH mobilizes calcium into circulation, but its effects on phosphate are different. So PTH decreases the renal phosphate reabsorption, causing more phosphate to be peed out. And so the overall result is an increase in serum calcium combined with a decrease in serum phosphate. This difference between calcium and phosphate handling is the most useful way to remember the hormone's actions. So PTH activates vitamin D, releases calcium from bone, and preserves calcium in the kidney, but promotes renal phosphate loss. So the memory hook here is that PTH saves calcium while wasting phosphate. All right, so bone is metabolically active and continuously remodeled rather than remaining static after it forms. Calcium and phosphate are constantly added to and removed from the skeleton. Under normal conditions, osteoclast-mediated bone resorption is coupled to osteoblast-mediated bone formation. So remodeling also allows bone to change its structure in response to mechanical stress. 3 major features describe this process: turnover, mineralization, and volume. Turnover refers to the balance between resorption and formation. This balance is influenced by osteoclasts, osteoblasts, hormones, and mechanical stimuli. Mineralization describes the degree to which osteoid becomes mineralized. So it depends on vitamin D and mineral availability, and is also influenced by acidosis and aluminum. Volume refers to the total amount of bone present. So bone volume is influenced by age, sex, genetics, and nutrition. These features are related to, but describe, different aspects of skeletal health. Turnover asks how rapidly bone is being removed and replaced. Mineralization asks how effectively osteoid receives mineral. And volume asks how much bone is present overall. All right, so rank and rank L signaling controls osteoclast development and therefore regulates bone resorption. Rank is located on osteoclasts and their precursors. When activated, it stimulates NF-kappa beta signaling and promotes osteoclast differentiation, function, and survival. Rank L is produced by osteoblasts and marrow stromal cells. So it binds to rank on osteoclast precursors, stimulating their formation and activation. This demonstrates how bone-forming osteoblast lineage cells help control bone-resorbing osteoclasts. Osteoprotegrin provides the opposing signal, so it is also produced by osteoblasts and stromal cells, but it acts as a decoy receptor for rank L. So by binding rank L before it reaches rank, osteoprotegrin prevents rank activation and inhibits osteoclast development. The amount of bone resorption therefore depends on the balance between rank L and osteoprotegrin. More effective rank L signaling promotes osteoclast activity and bone loss, while greater osteoprotegrin activity blocks this pathway and protects bone. The memory hook is that rank L accelerates resorption, whereas osteoprotegrin protects skeleton. I always like to remember that rank is responsible for bone resorption because if you stumble across like a graveyard of bodies or a place where a lot of death has happened, it smells rank. So that's how I remember that it has to do with bone death, or bone resorption rather. All right, so congenital skeletal disorders can be organized according to the developmental process that is disrupted. So abnormal migration or condensation during skeletal development produces dysostosis, okay, which may affect a single bone or a related group of bones. The resulting abnormality may include complete failure of a bone to form, called bone aplasia, the formation of extra bones, or inappropriate fusion between skeletal structures. So a different group of disorders results from mutations that interfere with the growth of bone or cartilage. Abnormal bone development is described as osteodysplasia, while abnormal cartilage development is described as chondrodysplasia. The examples introduced here include osteogenesis imperfecta, achondroplasia, thanatophoric dysplasia, cleidocranial dysplasia, and osteopetrosis. The main idea is to first determine whether the disorder reflects abnormal formation of particular bone or a broader defect in bone or cartilage growth. All right, osteogenesis imperfecta, also called brittle bone disease, results from defective synthesis of type 1 collagen. A common mechanism is a dominant negative mutation in which one defective collagen chain disrupts the entire collagen molecule. The result is an inadequate amount of structurally normal bone, leading to recurrent fractures of skeletal deformity. These fractures may sometimes be mistaken for child abuse. So type 1 is the most common form and is autosomal dominant. Its classic combination is recurrent fractures, blue sclera, and presenile hearing loss. Type 2 is a severe neonatal form in which fractures are already present at birth and is frequently lethal. Type 3 may follow autosomal dominant or autosomal recessive patterns. Approximately 2/3 of the affected population have fractures at birth, followed by progressive skeletal deformity. Type 4 is autosomal dominant and features normal sclerae, while the teeth may be normal or may demonstrate dentinogenesis imperfecta. So for a rapid recognition, recurrent fractures with blue sclera and hearing loss point most strongly to type 1 osteogenesis imperfecta. And you can remember type 1 collagen from that type 1 osteogenesis imperfecta. And by the way, the blue sclera is there because since it's a defect in collagen, you are quite literally seeing the vasculature underneath your eye, which is why you see a blue sclera. So similar to how you see your veins in your skin when you have thin skin, same thing happens with your eyes here. All right, so achondroplasia is the most common form of dwarfism and is caused by activating a mutation in the FGFR3 gene. It is inherited in an autosomal dominant pattern, although many cases arise from spontaneous mutations. FGFR3 normally inhibits growth plate chondrocytes, so an activating mutation exaggerates this normal inhibitory effect. Growth at the epiphyseal plates is therefore suppressed, reducing the length of the long bones, and so the affected process is endochondral ossification, which explains why the long bones are primarily involved, while the cranial bones are relatively spared. Clinically, this produces short stature with disproportionate proximal shortening of the extremities. Frontal bossing and midface hypoplasia are also characteristic, and so the high yield chain is an activating FGFR3 mutation leading to excessive inhibition of growth plate cartilage, impaired endochondral ossification, shortened long bones, and proximal limb shortening. Thanatophoric dysplasia. So thanatophoric dysplasia is a severe and usually lethal skeletal dysplasia caused by a mutation in the extracellular domain of the FGFR3 gene, and this mutation produces excessive inhibition of cartilage growth, leading to extreme shortening of the limbs. Patients may also have frontal bossing, but the most important clinical feature is a very small thorax. The severely reduced thoracic size leads to respiratory failure and explains why the disorder is usually lethal. This creates the key distinction from achondroplasia. Both conditions involve FGFR3 and produce shortened long bones and frontal bossing, except achondroplasia causes proximal limb shortening and midface hypoplasia, but is compatible with survival and adulthood. Thanatophoric dysplasia causes a much more extreme limb shortening along with severely reduced thoracic cage and respiratory failure. Therefore, when comparing these disorders, the small thorax and the lethal respiratory consequence points towards thanatophoric dysplasia. An easy way to remember thanatophoric dysplasia is like the lethal form of achondroplasia is that Thanos, Than is like the Latin name of the god of death, and also you can remember Thanos from Marvel, MCU, and so you just remember that guy brings death. So when you see thanatophoric dysplasia, you can remember Thanos, death, small thoracic cavity, yada, yada, yada. All right, cleidocranial dysplasia, also called cleidocranial dysostosis, is often sporadic but may follow an autosomal dominant inheritance pattern. It's often associated with chromosome CP21. The defining skeletal abnormality is partial or complete absence of the clavicles. Affected patients may also have short stature and small thorax, with respiratory difficulty occurring during infancy. Dental findings are especially important. Eruption of the permanent teeth is delayed, and numerous supernumerary or extra teeth may be present. Skull findings include brachycephaly along with frontal, parietal, and occipital bossing. Additional skeletal abnormalities include delayed ossification of the pubic bones, a broad femoral head, a short femoral neck, and a long second metacarpal. The most efficient exam pattern is absent or markedly underdeveloped clavicles combined with delayed eruption of numerous extra teeth. And I use a way to remember this one is Gaten Mazzarato, the actor from Stranger Things. He has cleidocranial dysplasia. So if you just think of Stranger Things when you think of cleidocranial dysplasia, there you go. Shout out to Gaten. I feel like his existence in Hollywood put this dysplasia like on the map because they even incorporate it into the show, which is kind of cool. And then the other Hollywood connection here is that the girl from Hereditary that gets decapitated, for all my horror fans out there, she also has cleidocranial dysplasia. So there you go, two actors in two movies to remember this. I can't recall her name though. All right, so osteopetrosis is also called marble bone disease or Albers-Schoenberg disease. It results from defective osteoclast-mediated bone resorption. Because old bone is not removed normally, bone mass increases and the skeleton becomes abnormally dense. However, this dense bone is structurally weak and may fracture like chalk. The autosomal dominant adult form is usually mild, while the autosomal recessive infantile form is severe. Clinical manifestations include recurrent fractures and cranial nerve palsies caused by narrowing of the skull foramina. Excess bone also reduces marrow space, and severe causes may lack a functional medullary cavity. Reduced marrow space contributes to increased susceptibility to infection. The central paradox is that an increased quantity of bone does not guarantee increased bone strength. So in osteopetrosis, impaired resorption produces more bone, but the bone is brittle and can compress the spaces normally reserved for marrow and cranial nerves. All right, so The central molecular problem in osteopetrosis is impaired acidification of the osteoclast resorption pit. Without adequate acidification, osteoclasts cannot effectively dissolve mineralized bone, so normal bone resorption fails. Two associated mutations help explain this process. CA2 encodes carbonic anhydrase 2, which generates protons from carbon dioxide and water, so these protons are required to create the acidic environment used during resorption. CLCN7 encodes a chloride channel that is also required for osteoclast acidification. A defect in either component interferes with formation of the acidic resorption environment, and so the result is failed bone removal, accumulation of abnormally dense but brittle bone, and narrowing of the marrow spaces and bony foramina. The highlight yield sequence is CA2 or CLCN7 defect, leading to inadequate acidification, ineffective osteoclast reabsorption, and the characteristic dense yet fragile skeleton. Sorry, that was my cat Otter again contributing to the lecture. All right, so this comparison slide condenses each congenital bone disorder into its most recognizable clue. A type 1 collagen defect indicates osteogenesis imperfecta, and recurrent fractures accompanied by blue sclera specifically favor type 1 disease. An activating FGFR3 mutation indicates achondroplasia, which suppresses growth of long bones. An FGFR3 mutation combined with severely reduced lethal thoracic cage instead indicates thanatophoric dysplasia. Absent clavicle accompanied by supranumerary teeth point towards cleidocranial dysplasia. Failed osteoclast-mediated resorption with dense but brittle bone identifies osteopetrosis. At the molecular level, mutations involving CA2 or CLCN7 also support osteopetrosis. Because these defects interfere with acidification required for bone resorption. The fastest approach is to connect the structural clue to the underlying process. So defective collagen causes brittle bone, excessive FGFR3 activity suppresses cartilage growth, absent clavicles suggests cleidocranial dysplasia, and defective osteoclast function produces osteopetrosis. All right, so osteoporosis is an acquired reduction of bone mass that may be localized or diffused. The composition of the remaining bone is normal. The problem is that there is simply too little bone. Osteopenia refers generally to the decreased bone mass, while osteoporosis indicates bone loss severe enough to increase the risk of fracture. The slide divides its causes into primary and secondary categories here. So the primary cause are postmenopausal osteoporosis and senile osteoporosis. So secondary osteoporosis can result from endocrine disease, GI or nutritional disease, medications, immobilization, or chronic illness. As bone density decreases, the internal supporting structure becomes less substantial, making the skeleton more vulnerable to injury. The spine image illustrates how this loss of bone can contribute to vertebral compression fractures. So the essential distinction here is that osteoporosis is a quantitative loss of otherwise normally composed bone, with the degree of loss becoming clinically important once fracture risk rises. And you literally get that slumped positioning because your spine can no longer support the weight of your head. All right, so the development of osteoporosis depends partially on peak bone mass, which is determined by genetics, physical activity, and nutrition. A person who begins with greater peak bone mass can lose more bone before reaching the level associated with osteoporosis, so a higher starting point delays its development. In postmenopausal osteoporosis, decreased estrogen increases IL-1, IL-6, and TNF. These cytokines stimulate RANK and RANK-L signaling, while osteoprotegrin is suppressed. Together, these changes increase osteoclast activity and bone resorption. Age-related osteoporosis develops through a different imbalance, so osteoprogenitor cell replication decreases, so osteoblast activity declines, and fewer matrix growth factors are available. So physical activity also decreases, so these changes reduce the ability to form and maintain bone. So the major contrast is therefore increased osteoclast-driven resorption after menopause, versus decreased bone forming capacity with aging, although both pathways ultimately reduce total bone loss. All right, so in osteoporosis, the bone that remains is histologically normal, but the total quantity of bone is reduced, right? So the trabeculae become thinner and more widely spaced, weakening the internal framework of the skeleton. This is why osteoporosis is considered a quantity problem rather than a mineralization defect. So plain x-rays are relatively insensitive because approximately 30 to 40% of the bone must be lost before the changes become apparent on an x-ray. So the standard method for measuring bone mineral density is dual energy x-ray absorptiometry. What a name. So the major complications arise from skeletal fragility and include vertebral compression fractures, rib fractures, hip fractures, and other fragility fractures. Repeated vertebral injury may contribute to increased lumbar lordosis. So fractures can also create serious secondary consequences. So pain and loss of mobility may lead to prolonged immobility, which can be followed by pneumonia or a pulmonary embolism. These complications explain why osteoporotic fractures are associated with increased morbidity and mortality. All right, so Paget's disease of the bone, also called osteitis deformans, is characterized by excessive but disorganized bone remodeling. Although total bone mass increases, the newly produced bone is structurally weak because it's not organized normally. The disease progresses through 3 stages. So the first is the osteolytic stage, in which excessive osteoclast activity becomes increased, thus increasing bone resorption. And then the second is the mixed stage, during which osteoclasts continue removing bone while osteoblasts simultaneously produce new bone. And the third is the osteosclerotic stage, in which excessive and disorganized bone formation becomes dominant. Therefore, Paget's disease is not simply a condition of bone loss or bone gain, it is a disorder of uncontrolled remodeling that produces a greater quantity of weak bone. A useful laboratory clue is increased alkaline phosphatase, which reflects increased bone-forming activity. So the sequence to remember is excessive resorption, mixed resorption and formation, and then finally excessive disorganized formation. Right, so Paget's disease usually occurs during middle to late adulthood and may involve one bone called monoostotic or multiple bones, right, polyostotic. So approximately 15% of cases are monoostotic, while about 85% of cases are polyostotic. A paramyxovirus has been proposed as a possible mechanism, although this remains uncertain. Diseased bone contains increased IL-1 and IL-6, and approximately 10% of patients have SQSTM1 mutation. This mutation increases osteoclast formation through rank signaling, contributing to excessive remodeling. Morphologically, there is an increased amount of bone, but its architecture is poorly organized. The characteristic appearance is a mosaic or jigsaw puzzle pattern, and the resulting bone remains structurally weak despite its increased mass. Commonly affected sites include the femur, tibia, humerus, ilium, vertebrae, skull, and other parts of the axial skeleton. Many patients are asymptomatic, but complications may include bone or back pain, fractures, nerve impingement, high output cardiac failure, and secondary osteosarcoma. All right, so vitamin D deficiency produces defective mineralization. So in children with open growth plates, this condition is called rickets, which I have a whole slide for. And in adults with closed growth plates, it's called osteomalacia. So causes include decreased sunlight exposure, inadequate dietary vitamin D, and inadequate dietary calcium. So the pathogenesis begins when hypocalcemia stimulates parathyroid hormone, and then PTH and vitamin D then promote calcium retention and mobilization in an attempt to maintain available calcium. However, PTH also increases renal phosphate loss, so the result is low phosphate, which will interfere with normal bone mineralization, so the bone matrix cannot be mineralized effectively. In adults, the associated findings may be subtle and can include bone loss, bone and joint pain, muscle cramps or weakness, fatigue, and mood changes. When vitamin D status is being evaluated, serum 25-hydroxy vitamin D is the best test because it accurately reflects the body's total vitamin D supply. The central concept is defective mineralization caused by inadequate vitamin D availability and the resulting calcium phosphate imbalance. All right, so rickets is a mineralization disorder, like we said on the previous slide, of the growing bone. So because the growth plates are still open, defective mineralization produces prominent deformities at growth plates and load-bearing parts of the skeleton. So cranial findings include parietal bones buckling over pressure and then springing back, and then as well as frontal bossing and an unusual skull shape in general. So overgrowth at the costochondral junction produces the rachitic rosary. So chest Abnormalities may include pigeon breast and the Harrison groove, which is produced by the inward pulling of the diaphragm. And then you have the weakened skeleton, which may also develop lumbar lordosis and abnormal spinal curve, wide ankles, and bowing of the legs. So dental problems and muscular weakness may also be present here. Microscopically, the bone and osteoid are just poorly mineralized, and the high yield point is that rickets affects bone that is actively growing, so the most visible changes occur when growth and mechanical loading place the greatest risk on inadequately mineralized tissue. All right, so rickets, osteoporosis, and then osteomalacia. These three disorders are best distinguished by asking whether the problem is bone quantity or bone mineralization. So rickets, again, occurs in children with vitamin D deficiency and open growth plates. So the mineralization defect affects growing bone, producing skeletal deformities. Osteomalacia is the adult counterpart. So again, it occurs with vitamin D deficiency after the growth plates have closed and also reflect defective mineralization. The resulting bone is soft and prone to fracture, but the growth plate deformities of rickets do not occur because skeletal growth is complete. Osteoporosis is fundamentally different. The remaining bone is normally mineralized and histologically normal, but the total amount of bone is decreased. So this reduced quantity increases the risk of fragility fractures. So the fastest discriminator is therefore that osteoporosis means too little normally mineralized bone, whereas rickets and osteomalacia mean poorly mineralized bone, and then age and growth plate status then separate rickets in children from osteomalacia in adults. All right, so hyperparathyroidism. So parathyroid hormone, again, increases rank L expression on osteoblasts, which is going to increase osteoclast-mediated bone resorption. PTH also increases renal calcium reabsorption, increases urinary phosphate excretion, and increases production of active vitamin D. Normally, a rise in serum calcium suppresses further PTH secretion. With excess PTH, however, osteoclast activity remains elevated, causing bone loss and replacement of bony and connective tissue. So primary hyperparathyroidism results from disease within the parathyroid glands, such as parathyroid adenoma or parathyroid hyperplasia. In this setting, PTH secretion is autonomous. So secondary hyperparathyroidism is a compensatory response to chronic hypocalcemia caused by disease outside of parathyroid glands. Chronic kidney disease is the most common cause listed here. So tertiary hyperthyroidism develops after long-standing secondary stimulation. So the parathyroid glands become autonomous and PTH remains elevated even after the original stimulus is corrected. So the key distinction is autonomous secretion in primary disease, appropriate compensation in secondary disease, and then an acquired autonomy following prolonged secondary stimulation in a tertiary disease. All right, so excessive parathyroid hormone increases osteoclast activity, decreases the amount of bone, and promotes replacement of bone by fibrous connective tissue. Severe hypoparathyroid bone disease is called osteitis fibrosa cystica and may produce cystic lesions known as brown tumors. Microscopically, these lesions contain a collection of osteoclasts and reactive giant cells. Hemorrhage is also present, and hemosiderin deposited after bleeding gives the lesion its characteristic brown color. Despite its name, a brown tumor is not a true neoplasm. It is a reactive manifestation of excess bone resorption associated with hyperparathyroidism. So the high-yield relationship is persistent excess PTH leading to increased osteoclast activity, bone loss, fibrous replacement, hemorrhage, and accumulation of hemosiderin. When a lesion containing giant cells and brown discoloration appears in the setting of a hyperparathyroid bone disease, it should be understood as a reactive brown tumor rather than an independent tumor. So the metabolic bone diseases on this slide can be separated by identifying the main abnormality. So osteoporosis is a quantitative disorder, right? There's a decreased amount of normally mineralized bone. The remaining trabeculae are thin and widely spaced, producing fragility fractures. Paget's disease is a remodeling disorder characterized by excessive disorganized bone turnover. Bone mass increases, but the new bone is weak and shows a characteristic mosaic pattern. Increased alkaline phosphatase reflects the elevated bone forming activity. Rickets and osteomalacia are mineralization disorders related to vitamin D deficiency. Rickets occurs in children, while osteomalacia occurs in adults. Hyperparathyroidism is driven by increased rank L expression and osteoclast activity. Bone is lost and replaced by fibrous tissue, and severe disease may produce brown tumors. The fastest comparison is that osteoporosis has too little normal bone, Paget's disease has too much disorganized weak bone, and then rickets and osteomalacia have poorly mineralized bone. And hyperparathyroidism produces osteoclast-mediated resorption with fibrous replacement. All right, so renal osteodystrophy refers to altered bone morphology in patients with chronic kidney disease. Multiple pathways contribute to skeletal changes. So reduced renal phosphate excretion causes phosphate retention, and this retained phosphate contributes to hypocalcemia. At the same time, reduced renal 1-alpha hydroxylase activity decreases the production of active vitamin D. So lower active vitamin D reduces intestinal calcium absorption, further contributing to chronic hypocalcemia. Persistent low calcium stimulates the parathyroid glands and produces secondary hyperparathyroidism. The resulting elevation in PTH increases bone turnover and bone resorption. Renal osteodystrophy is therefore not a single uniform pattern of bone disease. Its classification evaluates 3 separate features: whether bone turnover is low, normal, or high, whether mineralization is normal or abnormal, and whether overall bone volume is low, normal, or high. The central pathway is impaired kidney function, leading to phosphate retention and decreased active vitamin D, followed by hypocalcemia, secondary hyperparathyroidism, and altered skeletal remodeling. All right, so fractures can be classified by how far breaks extend through the bone. A complete fracture passes through the entire diameter of the bone, whereas an incomplete fracture is, well, incomplete. There you go. Fractures are also described according to the integrity of the overlying skin. So in a closed fracture, guess what? The skin remains intact. It's closed. This was formerly just called a simple fracture, but in an open fracture, guess what? The fracture communicates with the external environment through a skin wound. So the skin is open. So the older term is a compound fracture for that. The key point is that complete versus incomplete describes the extent of bony injury, while open versus closed describes that relationship between fracture and skin. So these are independent features, so both should be included when describing an injury. All right, and then so more classifications here. So a complete fracture description combines several independent characteristics, right? So the fracture line may be transverse, oblique, or spiral. Its location within a long bone may be epiphyseal, metaphyseal, or diphyseal. Fragmentation is described as non-communicated when there is a single fracture line without fragmentation, or communicated when the bone is broken into multiple fragments. Alignment is also important. So in a non-displaced fracture, the fracture ends remain in their normal alignment, whereas in a displaced fracture, those ends are no longer aligned. A full description may therefore state whether the fracture is complete or incomplete, opened or closed, transverse, oblique, or spiral, epiphyseal, metaphyseal, or diphyseal, and then displaced or non-displaced, and communicated or non-communicated. Each term answers a different question about the injury. And again, one of our rapid review slides. So this slide brings together the fastest recognition clues for the preceding bone disorders. So osteoblast-derived rank L activates osteoclast, while osteoprotegrin blocks rank L and therefore decreases bone resorption. Blue sclera, recurrent fractures, and hearing loss identify type 1 osteogenesis imperfecta. FGFR3 activation with proximal limb shortening indicates achondroplasia, whereas FGFR3 defect accompanied by a lethal small thorax indicates thanatophoric dysplasia. Absent clavicles with extra teeth suggest cleidocranial dysplasia. Dense but brittle bone with cranial nerve palsy point toward osteopetrosis. Osteoporosis is defined by normal bone composition with reduced bone mass. Mosaic pattern bone with elevated alkaline phosphatase suggests Paget's disease. Vitamin D deficiency in a child produces rickets. A brown tumor is associated with hyperparathyroidism, and chronic kidney disease with secondary hyperparathyroidism produces renal osteodystrophy. So the basic biomechanics of bone. So bone can be injured by several types of force. Compression pushes inward, tension stretches or pulls, and then shear involves parallel forces moving in opposite directions. Bending produces compression on one side and tension on the other, and rotation or torsion twists the bone. Bone's mechanical properties reflect its components. So mineralized hydroxyapatite provides rigidity and resistance to compression, while type 1 collagen provides flexibility and tensile strength. When force temporarily changes the bone's shape and the bone returns to normal after the force is removed, this is elastic deformation and occurs below the yield point. Once force exceeds the elastic range, plastic deformation occurs, producing a permanent change in shape. Fragments may no longer be capable of complete reapproximation. If the force exceeds the bone's failure point, structural continuity is lost and a fracture then occurs. Incomplete fractures. So incomplete bone injuries include several related patterns. So plastic deformation is permanent bending without complete structural failure. A bone bruise consists of trabecular microfractures caused by a compression and is usually detected with MRI rather than plain radiographs. A torus or buccal fracture occurs when longitudinal compression causes the cortex to buckle outward. This pattern is common in children. A green stick fracture is incomplete transverse fracture produced by bending. In a green stick injury, the cortex fails on the tension side while the opposite cortex remains intact. A depressed fracture occurs when a bony fragment is displaced inward and classically affects the skull after a direct impact. The unifying concept is that incomplete fractures do not pass through the entire diameter of the bone, although they can still produce permanent deformation or localized cortical failure. So complete fractures extend through the full diameter of the bone and may be classified by the direction of the fracture line. In a transverse fracture, the line is perpendicular to the long axis of the bone and is often produced by direct force or bending. An oblique fracture has a diagonal fracture line and is often produced by combined compression and bending. A spiral fracture wraps around the bone and is produced by torsional or rotational force. The fracture pattern therefore provides information about the force that caused the injury. Importantly, a spiral fracture in a child is not automatically evidence of abuse. Okay, the fracture must be interpreted together with the history of the injury and the child's developmental ability, because the morphology alone does not establish how or why the twisting force occurred. All right, a communicated fracture occurs when bone is broken into 3 or more fragments. It is common after high energy trauma and may contain a triangular fragment, also known as butterfly fragment. So the shape and orientation of this fragment can help indicate the direction of the force. A segmental fracture is different. So 2 separate fracture lines isolate a free segment of bone between them. Segmental injuries are also associated with a major impact, such as a pedestrian being struck by a vehicle, and these patterns indicate substantial structural injury. The high-yield clinical implication is that displacement and accompanying soft tissue injury increases the risk of infection and delayed healing. Therefore, fracture complexity involves more than the number of lines. It also reflects how much the bone and surrounding tissues have been disrupted. So cranial fractures have several specific descriptive terms. In a depressed fracture, a portion of the skull is displaced inward, usually following a direct blow. Diastatic fracture extends along the cranial suture or separates that suture and is more common in infants and children. A ring fracture encircles the foramen magnum. This can result from a fall onto the feet or buttocks, which transmits that force upward from the forceful impact to the top of the head. And then the image also identifies linear and basilar fractures, but the major distinctions emphasized here are inward displacement in the depressed fracture, separation along the suture in a diastatic fracture, and a fracture surrounding the foramen magnum in a ring fracture. All right, a pathologic fracture occurs through bone that has already been weakened by another disease process. Because the bone is abnormal before it breaks, the fracture may occur after minimal trauma or even during normal activity. Examples of conditions that can weaken bone in this way include a primary bone tumor, metastatic carcinoma, multiple myeloma, a brown tumor caused by hypoparathyroidism, infection, or another destructive bone lesion. The important diagnostic idea is that underlying disorders lower the bone's ability to withstand ordinary force. So the slide also notes a terminology exception here. So fractures occurring in an osteoporotic bone are generally not called pathologic fractures in routine usage because osteoporosis and its associated fractures are very common. So instead, these are commonly discussed as osteoporotic or fragility fractures. So just know that if it's osteoporosis related, it's not a pathogenic fracture. So certain fracture patterns can help reconstruct the mechanism of injury. A Colles fracture is a distal radius fracture commonly caused by falling on an outstretched hand, or a fouche. A perifracture is an isolated fracture of the ulna, sometimes with involvement of the radius, and may occur when the forearm is raised defensively. And then you have a hyoid fracture, which may occur with strangulation or after a direct impact to the neck. A ring fracture around the foramen magnum suggests axial loading, such as landing on the feet or striking the top of the head. These associations show why fracture morphology can be clinically informative. The affected bone, fracture configuration, and direction of transmitted force may provide clues about the activity or trauma responsible for the injury. All right, so fracture healing follows a predictable sequence: hematoma and inflammation, soft callus formation, hard callus formation, and remodeling. Immediately after the fracture, ruptured blood vessels produce hemorrhage and fibrin deposition, creating a hematoma at the injury site. Neutrophils and macrophages then remove necrotic tissue. Next, granulation tissues develop, and fibroblasts and chondroblasts create a fibrocartilaginous bridge called the soft callus. This bridge provides early stabilization, but is not yet mature bone. During hard callus formation, woven bone is deposited and the cartilage mineralizes through a process resembling endochondral ossification. Finally, remodeling replaces the woven bone with a stronger laminar bone. So the architecture of the healed bone gradually adapts to the mechanical stresses placed upon it. The high-yield sequence to remember is hematoma, followed by soft callus, followed by hard callus, and then laminar remodeling. So pseudoarthrosis occurs when persistent motion at a fracture site prevents normal bony union. Instead of the fracture fragments being joined by a stable bony callus, fibrous tissues develop between them. Continued movement can actually create a false joint, which explains the term pseudoarthrosis. Pseudo meaning false, arthrosis referring to a joint. So the major cause is inadequate immobilization or excessive movement, which while the fracture is healing. So clinically, the patient may also develop chronic pain and abnormal mobility at the original fracture site, along with failure of the fracture to unite. So because normal healing has been disrupted, treatment may require surgical stabilization to eliminate movement and bone grafting to support the union. The key concept is that the fracture healing requires adequate stability. If the fragment continues moving, the body may connect them with fibrous tissue rather than bone, producing a painful and mobile non-union that behaves like a false joint. All right, so this slide links common fracture patterns to their underlying mechanisms and summarizes their healing sequence. So axial compression can produce a torus or buckle fracture because the cortex buckles under the compressive force. Bending can produce either an incomplete green stick fracture or a complete transverse fracture, depending on whether the bone fails completely. Rotation produces a spiral fracture because the fracture line wraps around the bone in response to twisting. High energy impact is associated with comminuted fractures. I've been saying it communicated. I meant to say comminuted fractures. And so in which the bone breaks into multiple fragments, or segmental fractures, in which two separate fractures lines isolate a free segment. Pathologic fracture occurs when another disease process has weakened the bone, allowing it to break during minimal trauma or normal activity, and then excessive movement during healing can prevent union and cause pseudoarthrosis. And finally, remember fracture healing sequence as hematoma, soft callus, hard callus, and remodeling. All right, so osteonecrosis, also called avascular necrosis, is the ischemic death of bone and marrow cells. The central problem is reduced blood flow, which may result from systemic vascular obstruction or local interruption in the bone's blood supply. In osteonecrosis, ischemic necrosis is the dominant disease process. This distinguishes it from osteomyelitis, where necrotic bone may also be present but develops in the setting of microbial infection and inflammation. The mechanistic sequence begins with reduced blood flow, followed by ischemia and the death of bone cells. So the death of bone is unable, the dead bone is unable to maintain its normal strength, so microfractures start to develop. Continued mechanical stress can cause structural collapse, and so the sequence is especially important near an articular surface because collapse can disrupt joint structure. So the key idea is that osteonecrosis begins as a vascular problem, but eventually becomes a mechanical problem as ischemic bone dies, develops microfractures, and loses its structural integrity. So the clinical effects of osteonecrosis depend heavily on whether the infarct is subchondral or medullary. A subchondral infarct is located directly beneath the articular cartilage. Because this region supports a joint surface, it is commonly painful and repeatedly exposed to weight-bearing forces. These forces promote the microfractures in the necrotic bone, which may lead to collapse and deformation of the articular surface. Once the joint surface is disrupted, secondary osteoarthritis can develop. A medullary infarct, by comparison, is located within the marrow cavity. It is usually clinically silent and often remains structurally stable unless it becomes very large. Therefore, subchondral osteonecrosis is generally more clinically important. Both represent ischemic injury, but the subchondral location places the damaged bone directly beneath load-bearing cartilage, making collapse and joint destruction much more likely than with that of an infarct confined to the medullary cavity. Right, so osteonecrosis can result from several mechanisms that ultimately reduce blood flow to bone, because that's the underlying issue. So the vascular lumen may be obstructed by fat, thrombi, or gas bubbles. Blood vessels may be compressed by increased pressure within the bone marrow, directly injured or interrupted after trauma. Whether the resulting ischemia becomes irreversible depends on its duration and severity, the patient's genetic susceptibility and vulnerability of the involved epiphysis, and the mechanical load placed on the affected bone. So major risk factors include glucocorticoid therapy, organ transplantation, systemic lupus erythematosus, sickle cell disease, decompression disease, fat emboli, excessive alcohol use, trauma, antiphospholipid antibodies, and Gaucher's disease. These conditions differ, but each can interfere with the delivery of blood to bone. So a useful memory hook from the slide here is that steroids, sickling, spirits, and pressure shifts, which will generally capture several classic settings associated with osteonecrosis. All right, so osteonecrosis can affect several vulnerable bones, particularly those with limited or terminal blood supplies. Legg-Calvé-Perthes disease, sorry for the pronunciation there, but I'm just going to power through that, is avascular necrosis of the femoral head occurring in children. So bisphosphonate-related osteonecrosis classically affects the jaw with greater risk during high potency or prolonged therapy and after invasive dental procedures. This shows up on my UWorld questions a lot, so keep that one in mind. Other commonly affected sites include the femoral head, medial femoral condyle, humeral head, scaphoid, lunate, and talus. The femoral head is emphasized because interruption of its blood supply can compromise the weight-bearing surface of the hip. So the slide's central principle is that limited blood flow increases vulnerability, right? If circulation is interrupted, the affected bone may not have enough alternative blood flow to remain viable. So for rapid recognition, connect childhood femoral head avascular necrosis with Legg-Calvé-Perthes disease and connect bisphosphonate-associated osteonecrosis with the jaw, especially in the setting of prolonged therapy or invasive dental procedures. All right, so osteonecrosis of the femoral head begins when reduced blood flow causes the death of the bone and the marrow cells. So the dead subchondral bone then develops microfractures under the mechanical stress, and as this process progresses, the articular surface may collapse, producing progressive destruction of the hip joint and potentially requiring hip replacement. The condition accounts for approximately 20,000 to 30,000 cases each year and about 10% of hip replacements. So it often affects younger active adults between the age of 20 and 40 years old. Common causes listed on the slide include alcohol use, glucocorticoids, trauma, sickle cell disease, antiphospholipid antibodies, Gaucher's disease, and idiopathic disease. The illustrated stages show how a progression from early necrosis beneath the joint surface to increasing collapse and deformity. So the major clinical concern is therefore not simply cell death, but the eventual failure of the weight-bearing femoral head and destruction of that hip joint. So osteomyelitis is inflammation of the bone and marrow caused by microbial infection. Organisms may reach the bone through hematogenous spread, direct inoculation after trauma or surgery, or contiguous spread from an adjacent soft tissue infection. So the distinction between acute and chronic osteomyelitis is based on histopathology. So acute osteomyelitis is characterized by neutrophilic inflammation, so whereas chronic osteomyelitis contains necrotic bone, fibrosis, and chronic inflammation. Acute disease is commonly hematogenic, meaning organisms travel through the bloodstream and seed into the bone. Chronic disease is more commonly followed commonly follows fractures, surgery, or contiguous spread from nearby infected tissue. So this classification reflects the dominant tissues responsible rather than simply the amount of time that symptoms have been present. So the high-yield framework to identify both the root and the histology is hematogenous spread with neutrophilic inflammation suggests acute osteomyelitis, whereas necrotic bone with fibrosis and chronic inflammation is going to suggest chronic osteomyelitis, right? It's been inflamed for some time, so the bone's been taking some damage, and there you go. All right, so acute osteomyelitis in children commonly presents with localized bone pain, fever, and a limp or reduced use of the affected extremity. So swelling and arrhythmia may also occur. The typical location is the metaphysis of the long bone because metaphyseal blood flow is slow and the region is highly vascular, promoting bacterial deposition. So the femur accounts for approximately 1/3 of the cases, while the tibia and fibula together account for approximately 1/4. Staph aureus is the most common organism. Other possible organisms include Strep pyogenes, Strep pneumonia, and group B Streptococcus, particularly in neonates. The key vignette is a child with fever and focal long bone pain, possibly accompanied by limping or refusal to use the limb. And this presentation should suggest hematogenous osteomyelitis involving the metaphysis until proven otherwise. So the location, systemic fever, and focal pain together provide the most useful recognition pattern here. All right, so osteomyelitis in adults may develop through hematogenous spread or by contiguous extension from a nearby source. Hematogenous disease is less common than it is in children and frequently involves the vertebral bodies, although the long bones, pelvis, and clavicle may also be affected. Contiguous osteomyelitis often follows trauma, surgery, prosthetic placement, a chronic wound, diabetic foot infection, in a more classic example there. So acute osteomyelitis usually has a rapid onset with fever, localized pain, and neutrophilic infiltrate. Staph aureus is the most common cause. Chronic osteomyelitis more often follows an open fracture, surgery, or contiguous infection and produces persistent or recurrent symptoms. Important findings include necrotic bone, fibrosis, reactive new bone, and a draining sinus tract. And then chronic infections may also be polymicrobial and fever may be absent. So evaluation can include blood cultures, C-reactive protein, and erythrocyte sedimentation rate. So the high-yield distinction is acute disease with neutrophils versus chronic disease with dead bone, sinus tracts, and reactive bone. All right, so 3 terms help describe the structural changes of chronic osteomyelitis. So sequestrum, involucrum, and sinus tract. So a sequestrum is the fragment of necrotic bone that has separated from the surrounding viable bone. Because it is dead and isolated, it can act as a protected reservoir in which the microorganisms persist. The involucrum is the reactive new bone that forms around the sequestrum, essentially wrapping new living bone around a dead fragment. A sinus tract is the channel that connects the infected bone with the skin surface and permits persistent drainage. So long-standing sinus tracts have rare but important association with the development of squamous cell carcinoma. So the simplest memory aid is that the sequestrum is the dead bone, right? It's sequestered, while the involucrum is the new bone surrounding it. And when a vignette describes chronic draining osteomyelitis with a central necrotic fragment and the necrotic bone and reactive bone formation, identify the central fragment as the sequestrum and the surrounding shell as the involucrum. All right, so the likely organism in osteomyelitis depends heavily on the clinical setting. So Staph aureus is the leading organism in most patients and remains possible in nearly every population. In neonates, important causes include group B strep, Staph aureus, and gram-negative organisms. In a patient with sickle cell disease, Salmonella species are the classic association. Although Staph aureus is still possible, contiguous infection or infection involving implanted hardware broadens the organism list to include Staph epidermidis. Pseudomonas aeruginosa or Serrata species, E. coli as well, and mixed infections. Immunocompromised patients may develop osteomyelitis from fungi or mycobacteria. The high-yield approach is to start with Staph aureus as the general answer, then use the patient's age, medical conditions, route of infection, and presence of hardware to refine the organism. So the strongest exam clue on the slide is the sickle cell disease combined with osteomyelitis, which should immediately suggest salmonella. All right, so tuberculous osteomyelitis occurs in approximately 1 to 3% of tuberculosis cases and usually reaches the skeleton through hematogenous spread. It commonly affects the vertebrae and long bones and may also involve oxygen-rich synovial tissues. Tuberculosis involving the vertebral column is called pot disease, and this infection can progressively destroy the vertebral bodies and cause them to collapse. As the vertebral structure is lost, the patient may develop spinal deformity and compression of nearby neurological structures, which can produce neurologic defects. So the major recognition pattern is therefore chronic back pain accompanied by vertebral destruction in someone at risk for tuberculosis. Unlike a rapidly developing acute bacterial process, the emphasis here is on chronic hematogenous infection with progressive structural damage. So for exam purposes, connect tuberculosis of the spine directly with Pott's disease. And remember that the major consequences described on the slide are the vertebral body destruction, collapse, spinal deformity, and possible neurologic compression. So syphilis can affect bone differently depending on whether the disease is congenital or acquired. Congenital syphilis may produce Hutchinson teeth, meaning notched upper incisors as well as mulberry molars. Other skeletal findings include saddle nose deformity with destructive gummas, saber shins caused by anterior bowing of the tibia, metaphyseal leukineses, and periostitis. So in adults, bone involvement is rare during secondary syphilis and is most commonly associated with a tertiary disease. So the skull, shoulder, and long bones may be involved, producing bone pain and periostitis. A gumma is a granuloma-like lesion associated with tertiary syphilis. It contains central necrosis surrounded by lymphocytes and plasma cells, and epithelioid histocytes may also be present. Because a gumma can destroy bone, it may produce significant deformity, and so the most efficient recognition clues here are Hutchinson teeth and saber shins for congenital syphilis, while a destructive, centrally necrotic granuloma-like lesion points towards a gumma of tertiary syphilis. So again, we have our rapid review here. So this slide is going to bring together the major recognition patterns from fractures, osteonecrosis, and osteomyelitis. So in a child, axial compression points towards a torus fracture, whereas bending injury suggests green stick fracture. Rotational force produces a spiral fracture, and an inadequate immobilization during healing may result in pseudoarthrosis. Steroid or alcohol exposure combined with hip pain should raise concern for osteonecrosis of the femoral head. A child with fever and focal long bone pain should be considered to have a metaphyseal osteomyelitis until proven otherwise. When osteomyelitis occurs in sickle cell disease, salmonella is the major organism clue, and chronic osteomyelitis, dead bone, is the sequestrum, whereas the surrounding reactive new bone is the involucrum. Tuberculosis involving the spine is Pott disease. Finally, the combination of Hutchinson teeth and saber shins identifies congenital syphilis, and these pairings are designed for rapid diagnosis, right? Identify the mechanism, population, exposure, location, or defining morphological feature and connect it directly to the corresponding condition. So neuromuscular junction disorders can be categorized according to whether the defect is presynaptic, within the synaptic space, or postsynaptic. So the major disorders introduced here are myasthenia gravis, Lambert-Eaton myasthenic syndrome, and congenital myasthenic syndromes. So normal neuromuscular transmission requires the motor neuron to release acetylcholine, which then binds acetylcholine receptors on the skeletal muscle motor end plate and produces muscle contraction. A deficit at any point in this pathway can impair contraction, but identifying the location of the deficit helps distinguish the disorders. So toxin-mediated syndromes also affect neuromuscular function, but produce very different patterns. Clostridium tetani is associated with sustained muscular contraction, whereas Clostridium botulism produces flaccid paralysis. The main high-yield task is localization. So ask whether the problem involves acetylcholine release from the presynaptic terminal, events within the synapse, or postsynaptic receptor and motor end plate. This localization framework will make the clinical differences between myasthenia gravis and Lambert-Eaton syndrome easier to understand. Myasthenia gravis is an autoimmune disorder of the postsynaptic neuromuscular junction. So it is most commonly caused by antibodies directed against the acetylcholine receptor, which reduce the number of functional receptors and impair neuromuscular transmission. Other possible antibody targets include muscle-specific receptor tyrosine kinase, or MuSK, and low-density lipoprotein receptors related protein 4, or LRP4. Clinically, myasthenia gravis causes fluctuating, fatigable skeletal muscle weakness, and so weakness becomes worse with repetitive activity and improves with rest. So patients may feel strong in the morning and weaker by the end of the day. So ptosis and diplopia are common early findings because involvement of the extraocular muscles is especially characteristic. Disease may progress to the facial, bulbar, neck, limb, and respiratory muscles, and so severe respiratory weakness may require mechanical ventilation. The key localization point is that myasthenia gravis is postsynaptic, and the key clinical pattern is weakness that worsens with use but improves after rest. Right, so the thymic association in myasthenia gravis varies with the age of onset. So early onset disease occurs before the age of 50, so it is more common in females and is associated with thymic enlargement or hyperplasia. Late onset disease occurs with a more similar frequency in males and females and is associated with thymoma. Because of these relationships, patients diagnosed with myasthenia gravis should undergo chest imaging to evaluate the thymus. A young patient with fatigable ocular weakness should particularly suggest thymic hyperplasia. Antibodies against MuSK are associated with a somewhat different weakness pattern. So these patients may have prominent weakness of the neck, face, shoulders, bulbar muscles, and respiratory muscles, and their presentation may therefore be more bulbar and respiratory than purely ocular. So the high-yield approach is to connect early onset disease with thymic hyperplasia and then later onset disease with a thymoma, and MuSK positive diseases with a prominent neck, facial, bulbar, and respiratory weakness. So Lambert-Eaton myasthenic syndrome is a presynaptic neuromuscular junction disorder. So autoantibodies target presynaptic voltage-gated calcium channels, reducing calcium entry into the nerve terminal and decreasing acetylcholine release. Extremity weakness is common, but unlike myasthenia gravis, the weakness improves with repeated use. So repeated stimulation allows calcium to accumulate in the presynaptic terminal, which improves acetylcholine release and strengthens the transmission. Lambert-Eaton syndrome is a paraneoplastic disorder that is strongly associated with small cell lung carcinoma. And so the contrast with myasthenia gravis is especially high yield here. So myasthenia gravis involves postsynaptic acetylcholine receptor defect, where it and commonly affects the ocular muscles, worsens with repeated activity, and associated with thymic hyperplasia or thymoma, whereas Lambert-Eaton involves presynaptic calcium channel defect, commonly causes extremity weakness, improves with repeated use, and is associated with small cell lung carcinoma. So the memory hook is that myasthenia gravis gets worse with use, whereas Lambert-Eaton loosens up. Right. Congenital myasthenic syndromes are inherited disorders caused by mutations in proteins that support neuromuscular junction function. Depending on which protein is abnormal, the defect may be presynaptic within the synaptic space or postsynaptic. So this location determines the clinical presentation. So these syndromes can resemble either myasthenia gravis or Lambert-Eaton myasthenic syndrome. So patients commonly experience muscle weakness that worsens with exertion and improves with rest, along with easy fatigability. Some forms produce ptosis, while involvement of the muscles used for swallowing may cause dysphagia, with a risk of choking or aspiration. The most important distinction is the underlying cause, right? So congenital myasthenic syndromes are genetic, whereas myasthenia gravis and Lambert-Eaton syndrome are autoimmune. Therefore, a myasthenic pattern beginning in a congenital or inherited setting should prompt consideration of an abnormal neuromuscular junction protein rather than just an acquired antibody. All right, so tetanus and botulism produce opposite patterns of paralysis because their toxins interfere with different parts of motor signaling. So Clostridium tetani produces tetanospasm, which blocks the release of inhibitory neurotransmitters from interneurons. Removing this inhibitory input increases motor neuron activity, so the muscles remain excessively activated. The result is sustained muscle contraction and spastic paralysis. Clostridium botulinum acts differently. So botulinum toxin prevents the presynaptic release of acetylcholine, causing neuromuscular transmission to fail. With acetylcholine reaching the muscle, contraction cannot occur normally, producing weakness and flaccid paralysis. So the fastest way to separate these disorders is just to focus on the muscle tone and the affected neurotransmitter pathway. So tetanus removes inhibition and therefore tightens the muscles, while botulism blocks acetylcholine release and leaves the muscle weak and flaccid. So in short, tetanus produces too much motor activity, whereas botulism prevents excessive motor activity. So normal skeletal muscle fibers are relatively uniform in size and appear polygonal, when viewed in cross-section. So in atrophic muscle, individual fibers become smaller and greater variation in fiber size develops. So the distribution of these small fibers is diagnostically useful because different patterns suggest different causes. So grouped atrophy points towards a neurogenic process, meaning that loss of a nerve input has affected groups of muscle fibers together. Parafascicular atrophy, in which abnormal fibers are concentrated around the edges of fascicles, suggests dermatomyositis. So selective atrophy of type 2 fibers is associated with disuse or corticosteroid exposure. So a scattered distribution of abnormal fibers is more consistent with a primary muscle disorder. So the high yield principle is that the biopsy pattern helps localize the problem. Groups of small fibers suggest denervation and therefore nerve-related cause, whereas scattered abnormal fibers suggest that the disease process originates within the muscle itself. All right, so peripheral neuropathy has a broad differential that can be organized into several major categories. So inflammatory causes include Guillain-Barré syndrome, chronic inflammatory demyelinating polyneuropathy, sarcoidosis, vasculitis, systemic lupus erythematosus, and rheumatoid arthritis. So infectious causes include leprosy, HIV/AIDS, Lyme disease, and varicella-zoster virus. Metabolic and nutritional causes include diabetes mellitus, renal failure, thiamine deficiency, and vitamin B12 deficiency. Additional causes include exposure to alcohol, arsenic, lead, and organophosphates, as well as trauma, paraneoplastic disease, monoclonal gammopathies, and hereditary neuropathies such as Charcot-Marie tooth disease. So when approaching a patient with peripheral nerve symptoms, this organizational framework helps keep the differential manageable. So first determine whether the clinical context suggests inflammation, infection, or metabolic or nutritional problem, a toxic exposure, trauma, malignancy-related disease, or an inherited neuropathy. The slide's main message is just that peripheral neuropathy is a pattern with many possible underlying causes. All right, so two basic peripheral nerve injuries, right? So peripheral nerve injuries can be divided into primary axonal damage or primary demyelination. In an axonal injury, the main structure damage occurs in the axon itself. So this commonly produces distal sensory symptoms and may interrupt nerve input to skeletal muscle, leading to denervation and muscle atrophy. In a demyelinating injury, the primary problem affects the myelin sheath or the Schwann cells that produce it. Loss of myelin slows or completely blocks impulse conduction, even though the axon may remain present. Clinically, demyelination often produces weakness involving both proximal and distal muscles, but it usually does not cause the substantial denervation atrophy associated with axonal loss. So the central distinction is therefore what has been damaged, right? Axonal disease destroys the conducting fibers themselves and can't disconnect the muscle from its nerve supply. And can disconnect the muscle from its nerve supply. So you're literally losing the nerve. Whereas demyelinating disease damages the insulation around the fiber, causing the signal to travel slowly or fail through conduction block. So one of them is you're just getting rid of the nerve altogether, and the other one's it's going to get there a lot slower, the signal, that is. All right, so axonal and demyelinating polyneuropathy. So axonal polyneuropathy commonly produces a length-dependent pattern in which symmetric distal sensory symptoms are more prominent than motor symptoms. So patients may report numbness, tingling, burning sensations, and the ankle stretch reflexes may be lost. So the high-yield pattern is symmetric distal sensory loss, reflecting greater vulnerability of the longest axons. Demyelinating polyneuropathies present differently. So weakness can involve proximal as well as distal muscles, and sensory loss is less likely to be the main presenting symptom because the primary defect is in myelin. So impulse conduction becomes slowed or maybe blocked. Importantly, the underlying axon may remain structurally intact, so a signal may still reach the muscle, but it just arrives more slowly or fails at an area of the conduction block, as we discussed previously. So therefore, distal sensory predominant symptoms suggest an axonal length dependent neuropathy, while combined proximal and distal weakness with slowed conduction supports a demyelinating process. All right, so acute axonal injury secondarily disrupts the surrounding myelin sheath. So axonal fragments surrounded by disintegrating myelin from structures called ovoids, so which are best visualized using electron microscopy or teased nerve preparations. So Schwann cells and macrophages then remove the damaged nerve fiber fragments by phagocytosis, and if regeneration occurs, Schwann cells guide the growing axons. So the regenerating fibers are small and closely packed, and their newly formed myelin internodes are shorter and thinner than normal. So with chronic axonal degeneration, there is an overall loss of myelinated axons in general. So increased endoneural connective tissue and clusters of regenerating nerve fibers. So axonal loss also has an important downstream effect on skeletal muscle. When axonal input is lost, the muscle is no longer receiving stimulus, and the deinnervated fibers develop neurogenic atrophy. So the key sequence is axonal damage, secondary myelin breakdown and cleanup, attempted Schwann cell guided regeneration, and possible chronic loss with muscle denervation. Segmental demyelination primarily damages the myelin sheath or the Schwann cell rather than initially destroying the axon. Myelin is lost from individual segments, particularly those adjacent to the nodes of Ranvier. When remyelination occurs, the replacement myelin is thinner than normal, and new internodes are shorter and unequal in length. So these structural changes help explain why conduction becomes slow or blocked even when the axons remain present. Repeated cycles of demyelination and remyelination stimulate proliferation of Schwann cells and their basement membranes around affected axons. So over time, these concentric layers produce the characteristic onion bulb appearance, and so the high yield association is therefore pretty straightforward. Onion bulb formations indicate repeated episodes of demyelination followed by remyelination, and this finding reflects a chronic process in which the nerve repeatedly loses and attempts to rebuild its myelin insulation rather than a single episode of primary axonal destruction. All right, so rhabdomyolysis is acute necrosis of skeletal muscle fibers with release of intracellular muscle contents into the bloodstream. So released substances include creatine kinase, myoglobin, potassium, phosphorus, and organic acids. The major complication is acute kidney injury. So many different insults can trigger this process, but traumatic causes include crush injury, burns, frostbite. Temperature-related causes include hypothermia, hyperthermia, while exertional causes include intense exercise and seizures. Metabolic triggers include hypokalemia, hypophosphatemia, hypocalcemia, diabetic ketoacidosis, and hypothyroidism. Other potential causes include ischemia, infection, electrical injury, or defibrillation. Inflammatory myopathies, drugs, toxins, and genetic metabolic disorders. The unifying concept is rapid muscle cell destruction followed by systemic release of substances that would normally remain inside of the muscle. Myoglobin release is particularly important because it connects the muscle injury to the risk of kidney damage and the characteristic dark urine shown on the slide here. So creatine kinase is the central laboratory marker of rhabdomyolysis. A level greater than 500 international units per liter supports the diagnosis, while a value greater than 5,000 indicates increased risk of acute kidney injury. So Electrolyte abnormalities reflect the release and redistribution of substances following muscle necrosis. Potassium and phosphorus released from damaged muscles produced hyperkalemia and hyperphosphatemia. Hypocalcemia may occur because calcium is deposited within the damaged muscle. Myoglobinuria can produce dark urine, and that's the classic exam clue, is a urine dipstick that is positive for blood despite the presence of few or no red blood cells. Organic acid release may elevate the anion gap. Another possible finding is a BUN or BUN to creatinine ratio below 10:1, and it may fall below 6:1. Overall, markedly elevated creatine kinase myoglobinuria. These characteristic electrolyte changes and evidence of kidney risk form a core laboratory pattern for rhabdomyolysis. All right, so rhabdomyolysis causes coagulative necrosis of skeletal muscle fibers. So the damaged myofibers lose their normal architecture and calcium may become deposited within the injured muscle. As the process begins to resolve, macrophages enter the tissue and help remove the necrotic material. The major systemic consequence involves the kidneys. So myoglobin released from damaged muscle enters the circulation and then is filtered by the kidneys and forms pigmented casts within the renal tubules. So these myoglobin casts, together with hypovolemia, contribute to the development of acute kidney injury. So the high-yield pathologic connection is therefore between necrotic skeletal muscle and pigmented myoglobin casts in the kidney. So when rhabdomyolysis is suspected, remember that the disease is not confined to the muscle. The products released from the dying myofibers can produce serious renal injury. So now some myopathy terminology. So a myopathy is any abnormal condition or disease involving muscle tissue. So it's a broad category rather than one specific diagnosis. Muscular dystrophy is more narrowly defined as an inherited muscle abnormality that causes muscle dysfunction and progressive deterioration. And this distinction matters because not every myopathy is inherited or progressively degenerative. Another major category is inflammatory myopathies, which include dermatomyositis, polymyositis, and then an inclusion body myositis. So these conditions all involve muscle disease with inflammation, but they differ in their clinical presentation, underlying mechanism, and microscopic pattern. So the main framework is to first determine whether the problem represents a general myopathy, an inherited muscular dystrophy, or an inflammatory myopathy. Within the inflammatory group, later slides distinguish dermatomyositis by its skin and vascular findings, polymyositis by direct T-cell mediated muscle injury without a rash, and inclusion body myositis by its characteristic distribution and degenerative inclusions. So dermatomyositis typically produces slowly progressive symmetric proximal muscle weakness. Patients therefore have early difficulty using muscles close to the trunk, while distal muscles generally become involved later. Myalgias can also occur. The muscle findings are accompanied by characteristic skin abnormalities. So a heliotrope rash is a lilac. Is a lilac discoloration of the upper eyelids and may occur with periorbital edema. Gotron papules are scaling erythematous lesions located over the extensor joints, and these findings are especially useful because they connect an inflammatory muscle disorder with recognizable rashes, right? So dermatomyositis can also extend beyond the skin and skeletal muscle. Systemic involvement may affect the esophagus, lungs, and heart, including interstitial lung disease and cardiac failure. So the most recognizable clinical pattern is therefore symmetric proximal weakness combined with either the heliotrope rash or Gotron papules with possible esophageal, pulmonary, or cardiac involvement, and that will be dermatomyositis. And you can remember that this one's dermatomyositis because of the derm involvement there, right? All right, so dermatomyositis is primarily an autoimmune microangiopathy, meaning that immune-mediated injury targets the small blood vessels supplying muscles. Complement becomes activated, and the C5b9 membrane attack complex, or MAC, is deposited in these vessels, and so the resulting capillary injury reduces the muscle's ability. It reduces the muscle's blood supply and produces ischemic muscle damage. So other vascular findings include loss of muscular capillaries and telangiectasias involving the nail folds, gums, and eyelids. Microscopically, mononuclear inflammatory cells are found in the perimysial connective tissue and around blood vessels. So the classic biopsy finding is parafascicular atrophy, in which muscle fibers at the edges of the fascicles become atrophic, and then you got segmental fiber necrosis, and regeneration may also occur, and C5b9 attack complex deposition can be demonstrated by immunohistochemistry. So the key connection is that complement-mediated vascular injury produces the ischemia, and then perivascular and perimysial inflammation and the characteristic parafascicular pattern of muscle atrophy. So with dermatomyositis, you want to be thinking complement did this, right? So several antibodies are associated with particular dermatomyositis presentations. You have anti-MI2 is associated with the classical cutaneous findings, especially Gotron papules and the heliotrope rash. Then you have anti-Jo1, and this is associated with the interstitial lung disease, arthritis, and mechanic's hand presentation. This combination is particularly important because inflammatory muscle disease accompanied by pulmonary involvement and mechanic's hand should suggest an anti-synthetase antibody, such as anti-Jo1. Anti-P155/P140 is associated with juvenile dermatomyositis and with paraneoplastic disease, and these antibodies are therefore useful for linking the diagnosis to a recognizable pattern rather than simply confirming that muscle inflammation is present. So for rapid recall, connect anti-MI2 with the characteristic rash, and I remember that because it's mediated by complement, right? So if someone were to compliment me on my rash, there you go, right? Me being that anti-MI, me. That's where I'm getting that from, okay? So that's kind of like my brain ladder to connect that. So connect anti-MI2 with the characteristic rash, anti-Jo with the interstitial lung disease, and then and arthritis and mechanic's hand. And I just think of a mechanic named Joe who's inhaled a lot of car fumes. And then so that's going to explain the lung disease. And then anti-P155 and P140 with juvenile or paraneoplastic dermatomyositis. And the way I make sense of that one is I see the double P and I go PP and I go, well, that's pretty juvenile. And there you go. All right, so juvenile and adult dermatomyositis share the same general disease category but have different high-yield associations. So juvenile dermatomyositis typically begins around 7 years of age. It is more commonly associated with calcinosis, meaning calcium deposition in tissues, and it may also be associated with lipodystrophy. Adult dermatomyositis usually presents during the 4th through 6th decades of life. Okay, and it's compared to the juvenile form, it is more commonly associated with myositis-specific antibodies and has greater heart and lung involvement. So adult disease may also be associated with an underlying malignancy. The patient's age, therefore, helps predict which accompanying findings should receive the most attention. So in a child, think particularly about calcinosis and possible lipodystrophy. And in an adult, you want to be thinking about disease-specific antibodies, cardiopulmonary involvement, and possibility of underlying malignancy. Right. Polymyositis produces proximal muscle weakness and myalgias, but does not cause the characteristic skin involvement of dermatomyositis. So the lungs and the heart may be affected and autoantibodies may be present, but its underlying mechanism is direct injury to muscle fibers by CD8 positive cytotoxic T cells. Correspondingly, the inflammation is located primarily within the connective tissue surrounding individual muscle fibers. Okay, so this is different from the perimysial and perivascular pattern seen on dermatomyositis because this is in the endomysium, right? It's in that connective tissue surrounding individual muscle fibers. Polymyositis also lacks parafascicular atrophy, which is a classic biopsy finding of dermatomyositis. So the practical distinction is that polymyositis resembles dermatomyositis in producing inflammatory proximal muscle weakness, but it occurs without the rash and without parafascicular atrophy. And then on pathology, this one is due to CD8 positive T cell injury and endomysial inflammation instead of the complement pathway, right, which was for dermatomyositis. All right, inclusion body myositis is the most common inflammatory myopathy in patients older than 65. It causes slowly progressive weakness with characteristic distribution involving the quadriceps and distal upper extremity muscles. Pharyngeal and esophageal muscles may also be affected here. Unlike some other inflammatory myopathies, it has no characteristic myositis associated antibodies. So inclusion body myositis shares several findings with polymyositis, including endomysial CD8 positive inflammatory cells, focal invasion of myofibers, and degenerating and regenerating muscle fibers. What distinguishes it are its degenerative features. So rimmed cytoplasmic vacuoles, TDP43 inclusions, beta amyloid, ubiquitin, endomysial fibrosis, and fatty replacement. The most useful exam pattern is an older adult with slowly progressive quadriceps and distal upper extremity weakness. On biopsy, endomysial inflammation combined with rimmed vacuoles strongly supports inclusion body myositis. So the inflammatory myopathies can be separated by their clinical pattern, immune mechanism, and biopsy findings. Dermatomyositis produces proximal weakness with a rash. It results from complement-mediated vascular injury and shows perimysial and perivesicular inflammation with perivesicular atrophy. Polymyositis also causes proximal weakness, but there is no rash. Its injury is mediated by CD8 positive T cells. Its inflammation is endomysial, and perivesicular atrophy does not occur. Inclusion body myositis typically affects older adults and has a different weakness distribution, especially involving the quadriceps and distal upper extremities. It also has endomysial inflammation, but the presence of rimmed vacuoles and protein inclusion identifies its degenerative component. For rapid discrimination, think rash and perivesicular atrophy for dermatomyositis, no rash with CD8 positive endomysial injury for polymyositis, and an older patient with quadricep weakness and rimmed vacuoles for inclusion body myositis. Toxic myopathies may result from prescription medications, recreational drugs, hormonal abnormalities, or critical illness. Several examples are especially important. Statins can produce toxic muscle injury and may progress to rhabdomyolysis. Chloroquine and hydroxychloroquine impair lysosomal function, producing lysosomal storage myopathy. Alcohol can also cause rhabdomyolysis with myoglobinuria and renal failure. Additional examples include myopathy associated with intensive care illness and thyrotoxic myopathy. The central idea is that muscle dysfunction does not always arise from an inherited or autoimmune disease. An external substance, systemic hormonal disturbance, or severe illness may directly impair muscle structure or function. So when evaluating possible myopathy, the medication history, recreational drug exposure, hormonal state, and recent critical illness are therefore essential pieces of the clinical picture. All right, so metabolic myopathies can persist in two broad patterns. The acute or episodic pattern appears when increased energy demands expose the muscle's inability to use stored fuel properly. Exercise or fasting can therefore trigger sudden muscle cramping and severe episodes that may progress to rhabdomyolysis. So the chronic pattern behaves differently. Instead of isolated attacks, the patient develops slowly progressive muscle damage and persistent weakness. So this weakness may extend beyond the extremities to involve truncal, respiratory, or cardiac muscle. The central distinction is the timing of symptoms, right? So episodic disease produces attacks in response to metabolic stress, whereas chronic disease causes ongoing dysfunction okay? So for exam questions, exercising and fasting are especially important clues because both require muscle to access stored energy. When symptoms consistently appear under those conditions, think about metabolic defect affecting the muscle's ability to use the fuel. All right, so this slide contrasts defects involving two major muscle fuels, fatty acids and glycogen. So carnitine palmitoyl transferase 2, or as I like to call it, CP2, deficiency impairs the transport of long-chain fatty acids into the mitochondria. Okay, because exercise and fasting increase the demand for stored fuel, either condition can trigger episodic symptoms and potentially rhabdomyolysis. McArdle disease instead involves myophosphorylase deficiency, which prevents efficient use of glycogen stored within the muscle. The characteristic presentation is exercise-induced cramping with possible episodic rhabdomyolysis. Acid maltase deficiency affects a different part of glycogen metabolism. It impairs the lysosomal conversion of glycogen to glucose and is also called acid alpha glucosidase deficiency. And so the main organizing principle is the location of the metabolic block, right? So CPT2 deficiency affects fatty acid transport into the mitochondria, whereas McArdle disease affects the use of muscle glycogen, and acid maltase deficiency affects lysosomal glycogen processing. Pompe disease is the severe form of acid maltase deficiency. Because acid maltase is needed for lysosomal glycogen processing, its deficiency allows glycogen to accumulate within muscle lysosomes. So this produces both skeletal and cardiac muscle involvement, and the clinical pattern depends on the age of presentation. So the infantile form causes severe weakness with prominent cardiac involvement, making the combination of early muscle dysfunction and cardiac disease especially important. The adult form is more slowly progressive and is characterized primarily by truncal and respiratory muscle weakness. Respiratory involvement matters because these muscles are essential for ventilation, right? So while truncal weakness can impair mobility and posture, it's just not a good combo. So the high yield concept is that Pompe disease is not merely a problem of glycogen availability, it's the lysosomal glycogen storage disorder in which accumulated glycogen damages muscle with severe cardiac involvement emphasized in infants and progressive truncal and respiratory weakness emphasized in adults. Ion channel myopathies result from abnormalities in skeletal muscle ion channels. Most of these disorders are inherited in an autosomal dominant pattern. Because ion channels regulate muscle excitability, their dysfunction may produce several different clinical patterns, including myotonia, hypertonia, or episodes of hypotonic paralysis. Myotonia refers to abnormal persistence of muscle contraction, whereas hypotonic paralysis presents as episodic loss of muscle strength and tone. These attacks may be associated with abnormal serum potassium, but the potassium level is not limited to one direction. During an episode of hypotonic paralysis, potassium may be increased, decreased, or even normal. That variation is important because it means periodic paralysis cannot be excluded simply because the potassium level is normal. The overall high-yield idea is that ion channel defects disrupt the muscle's ability to respond normally to electrical signals, producing intermittent abnormalities of contraction, relaxation, or strength. So several genes help organize the major ion channel myopathies. KCNJ2 is associated with Anderson-Tawil syndrome, which may combine periodic paralysis with cardiac arrhythmias and skeletal abnormalities. SCN4A mutation can produce a spectrum ranging from myotonia to periodic paralysis. So the same general gene category may be associated with either excessive muscle contraction or episodic weakness. CACNA1S is linked to hypokalemic periodic paralysis and represents the most common form of periodic paralysis listed on the slide. CLCN1 is associated with myotonia congenita, making it an important gene when delayed muscle relaxation is the major presentation. RYR1 is associated with susceptibility to malignant hypothermia. For rapid recognition, connect each gene to its defining clue, right? So KCNJ2 with Anderson-Tawil and arrhythmias, SCN4A with myotonia through periodic paralysis, CACNA1S with hypokalemic periodic paralysis, and CLCN1 with myotonic congenita, and RYR1 with malignant hypothermia susceptibility. Mitochondrial myopathies result from impaired mitochondrial ATP production. Because mitochondria supply cellular energy, tissue with high energy requirement are affected most severely. Manifestations may include muscle weakness, elevated creatine kinase, episodes of rhabdomyolysis, and chronic progressive external ophthalmoplegia. Ophthalmoplegia refers to weakness of muscles controlling the eye movement. So, and its chronic progression is an important clue to mitochondrial dysfunction. On muscle biopsy, the characteristic finding is ragged red fibers. And these form because abnormal mitochondria accumulate beneath the muscle cell membrane or sarcolemma. And so the result is a ragged appearance around the edge of the affected fibers, and many disorders caused by mitochondrial DNA abnormalities are maternally transmitted. So the inheritance pattern may also be diagnostically useful. So the key connection are impaired ATP production, involvement of high energy tissues, possible ophthalmoplegia, and ragged red fibers caused by sarcolemmal mitochondrial aggregates. I personally have someone in my life that has a mitochondrial disorder, and they found out late on in life. I mean, not late, but like probably around 40 or 50 years old, and they have a kid, and this is mitochondrially passed down. So that kid is guaranteed to have it. So it's kind of a scary thing, right? Because if you don't make ATP, I mean, that's everything, right? That's the source of life, right? So it's you get weaker, you can't talk, you basically develop brain damage because nothing's firing as fast as it could. It's a really sad one, but it's definitely one to keep in mind because man, is it tough. It's a tough one. All right, so MELAS or MELAS stands for mitochondrial encephalomyopathy, lactic acidosis, and stroke-like episodes. And this disease combines neurologic dysfunction with skeletal muscle dysfunction, reflecting the high energy demands of both tissues. So lactic acidosis is a central metabolic finding. Patients may experience reversible stroke-like episodes, although true infarction may eventually develop. A major diagnostic clue is that the lesions do not follow a single vascular territory. So this separates the stroke-like episodes of MELAS from a typical vascular stroke confined to the distribution of one vessel. So cytochrome C oxidase expression may also be abnormal. The classic mutation involves the mitochondrial tRNA leucine gene, so MTTL1. For rapid recognition, just focus on the combination of lactic acidosis, encephalomyopathy, and stroke-like neurologic deficit that cross vascular boundaries. And so when a stroke pattern does not represent normal vasculature anatomy, especially in the setting of muscle dysfunction and lactic acidosis, MELAS should be moved high onto that differential. All right, so Kearns-Sayre syndrome or KS syndrome and MERF or MERRF are mitochondrial disorders with different hallmark presentations. So Kearns-Sayre syndrome is recognized by progressive external ophthalmoplegia, pigmentary degeneration of the retina, and complete heart block. The combination is important, so eye movement weakness plus retinal disease and cardiac conduction abnormality strongly suggest Kearns-Sayre syndrome. And then you have MERF, which stands for myoclonic epilepsy with ragged red fibers, and it is maternally transmitted and produces myoclonus seizures, skeletal myopathy, and ragged red fibers on muscle biopsy. So cerebellar neuronal loss may also produce ataxia. MERF is usually caused by mitochondrial tRNA mutations, commonly involving mitochondrial tRNA lysine. So the fastest way to distinguish these disorders is by dominant organ pattern. So Kearns-Sayre centers on ophthalmoplegia, retinal degeneration, and heart block, while MERF centers on myoclonus, epilepsy, skeletal muscle disease, and ragged red fibers. Leigh syndrome is a mitochondrial disorder characterized by severe neurologic and muscular dysfunction. Clinical findings include lactic acidosis, arrest, or regression of psychomotor development, seizures, extraocular muscle palsies, weakness, and hypotonia. Developmental regression is especially important because it means a child loses previously acquired abilities or stops progressing normally. So the underlying brain injury has a characteristic distribution with symmetric damage to the brainstem nuclei. The thalamus and hypothalamus may be involved. This symmetric deep brain and brainstem patterns helps distinguish Leigh syndrome from disorders that cause scattered or asymmetric lesions. Genetically, Leigh syndrome is heterogeneous, and more than 30 genes may be responsible, and abnormalities can involve either mitochondrial DNA or nuclear DNA. And so the high-yield recognition pattern is a child with lactic acidosis, developmental arrest or regression, hypotonia or weakness, and symmetric injury involving the brain, deep brain structures, and the brainstem. All right, so this slide condenses the major mitochondrial diseases into a rapid recognition pattern. So MELAS produces lactic acidosis with stroke-like episodes that do not follow a normal vascular territory. Kearns-Sayre syndrome is identified by progressive ophthalmoplegia, retinal degeneration, and heart block. MERF presents with myoclonus, epilepsy, skeletal myopathy, and ragged red fibers. Leigh syndrome is associated with developmental regression and symmetric injury involving the deep brain and brainstem. More generally, mitochondrial myopathy should be considered when ophthalmoplegia occurs together with ragged red fibers on muscle biopsy. These patterns reflect the vulnerability of high-energy tissues, especially skeletal muscle, the nervous system, the eyes, and the heart. And so for exam purposes, first identify the dominant clinical feature, then match it to the syndrome. So non-vascular stroke-like episodes is going to be MELAS. Retinal and conduction disease suggests Kearns-Sayre, and then myoclonic epilepsy suggests MERF, and developmental regression with symmetric brainstem injury suggests Leigh syndrome. All right, so rapid review. So this slide brings together the classic clues used to organize, right, those neuromuscular disorders. So fatigable ocular weakness, especially fluctuating ptosis or diplopia that worsens throughout the day, suggests myasthenia gravis, in which antibodies impair postsynaptic acetylcholine receptors or associated proteins. In contrast, Lambert-Eaton syndrome often produces proximal weakness that temporarily improves with repeated use, and it results from antibodies against presynaptic voltage-gated calcium channels and has an important association with that small cell lung carcinoma. The pattern of paralysis also helps localize the problem. So tetanus produces spastic paralysis because tetanospasm blocks release of inhibitory neurotransmitter GABA and glycine. Botulism produces descending flaccid paralysis because botulism toxin blocks acetylcholine release at the neuromuscular junction. On biopsy, grouped muscle fibers atrophy suggests neurogenic injury because of several fibers belonging to the same motor unit lose their nerve supply. Perifascicular atrophy, meaning atrophy around the edges of the muscle fascicles, is characteristic of Thank you, Otter. I love my cat. Perifascicular atrophy, meaning atrophy around the edges of the muscle fascicles, is characteristic of dermatomyositis. Onion bulb formations develop when peripheral nerves undergo repeated cycles of demyelination and remyelination. And then a dramatically elevated creatine kinase level with myoglobin in the urine indicates rhabdomyolysis, which can cause acute kidney injury and dangerous electrolyte abnormalities. Recurrent exercise-induced rhabdomyolysis should raise concern for metabolic myopathy affecting glycogen, fatty acid, or mitochondrial energy production. In an older adult, slowly progressive quadriceps and finger flexor weakness with rimmed vacuoles suggest inclusion body myositis. Rigidity and rapidly rising temperature after exposure to certain anesthetics suggest RYR1 associated malignant hypothermia, while ragged red fibers on muscle biopsy indicate abnormal mitochondrial accumulation and point towards mitochondrial myopathy. Right, so the first step in organizing inherited muscle disease is to distinguish muscular dystrophies from congenital muscular dystrophies and congenital myopathies. So a muscular dystrophy is an inherited disorder characterized by progressive muscle fiber degeneration. Although the genetic defect is present from conception, weakness is usually not obvious at birth. Muscle fibers repeatedly become damaged, regenerate up for a time, and then eventually lose the ability to repair themselves. So the lost muscle is progressively replaced by fat and fibrous tissue, producing persistent weakness and sometimes pseudohypertrophy. Congenital muscular dystrophies follow the same basic destructive process, but they are clinically apparent at birth during early infancy. Affected infants may present with hypotonia, weakness, delayed motor development, or contractures. Because these are dystrophies, the muscle continues to degenerate over time rather than remaining structurally abnormal but relatively stable. Congenital myopathies are also present at birth or infancy, but they are usually non-progressive or slowly progressive. So they are commonly named according to the characteristic structural finding on muscle biopsy, such as central cores, Niemelin rods, or centrally located nuclei. The most important distinction is therefore not simply whether the disease is congenital. Instead, ask what happens over time. Progressive destruction and replacement of muscle indicates congenital muscular dystrophy, whereas relatively stable structural deficit indicates a congenital myopathy. All right, so dystrophin is a large structural protein that protects muscle fibers during contraction. It connects the intracellular actin cytoskeleton to the dystrophin-associated glycoprotein complex in the cell membrane, which then links the muscular fiber to the surrounding extracellular matrix. So you can think of dystrophin as a shock absorber that transfers mechanical force when stabilizing the sarcolemma. So when dystrophin is absent or severely reduced, repeated muscle contraction places excessive stress on the sarcolemma, and small membrane tears allow calcium to enter the muscle fiber, activating destructive enzymes and causing myofiber necrosis. Early in the disease, satellite cells attempt to regenerate the injured fibers, and over time, however, repeated degeneration exhausts the muscle's repair capacity. So functional muscle is then replaced by fat and fibrosis, producing progressive weakness and the apparent enlargement of the calves, known as pseudohypertrophy. The images demonstrate Gower sign, which is a classic consequence of proximal pelvic girdle weakness. So because the hip and thigh muscles cannot generate enough force to raise the trunk directly, the child first rolls into a prone position, pushes the arms upward, and then uses the hands to walk up to the legs. So the key sequence to remember is dystrophin deficiency, followed by membrane instability, calcium entry, and necrosis, attempted regeneration, failed repair, and finally replacement by fat and fibrosis. Fun fact about Duchenne's muscular dystrophy, I took a genetics class in undergrad, and I was on the quarter system, so it's like 12 weeks. 10 of those weeks literally just focused on Duchenne's muscular dystrophy. Maybe not 10, maybe more like 8, but it felt like 10. Just literally Duchenne's muscular dystrophy, and it got drilled into my brain so hard. And I remember I was complaining about it one day, and I was talking to one of my friends who is a physician, and I was telling them about the weird hyperfixation on Duchenne's muscular dystrophy, and she was like, "Dude, are you serious? Oh my God, the guy who discovered Duchenne's muscular dystrophy was my professor in college at University of Pittsburgh, and his entire genetics lecture was literally all about Duchenne's muscular dystrophy because it was his research." And apparently he was just kind of an annoying professor. It's just funny. It was just like, you're always one deviation away from like some crazy stuff. But anyway, I just thought that was pretty interesting and wanted to share. All right, so Duchenne and Becker muscular dystrophies are both caused by pathogenic variants in the dystrophin gene on XP21. They are inherited in an X-linked recessive pattern, so they primarily affect boys, while female carriers may have mild skeletal muscle symptoms or cardiomyopathy. Both disorders cause progressive proximal weakness, elevated creatine kinase, calf pseudohypertrophy, Gower sign, and possible dilated cardiomyopathy. The major difference is whether the major difference is whether the mutation preserves the reading frame. So Duchenne's muscular dystrophy is caused by an out-of-frame mutation. So the altered reading frame prevents production of usable dystrophin, leaving little to no functional protein. This produces earlier onset, often between ages of 2 and 3, with more severe and rapidly progressing course. And cardiac and respiratory muscle involvement become major sources of the morbidity. Becker muscular dystrophy is usually caused by an in-frame mutation, so the reading frame remains intact, so the resulting dystrophin may be shorter or reduced in amount, but retains the same function. So Becker, therefore, tends to present later and progresses more slowly, although severity can vary considerably and cardiomyopathy may still be important. So the simplest memory aid is just to remember that Duchenne disrupts the reading frame and essentially deletes dystrophin function, whereas Becker's keeps the frame and retains some dystrophin function. Becker's is better. All right, so less functional dystrophin means earlier and more severe disease. All right, so myotonic dystrophy type 1 is an autosomal dominant multisystem disorder caused by expansion of CTG trinucleotide repeat in the DMPK gene. Okay, and the repeat can expand when transmitted to the next generation, producing what's called anticipation, which is disease begins earlier and is often more severe in successive generations. So very large expansion can cause congenital myotonic dystrophy, classically transmitted from an affected mother with severe neonatal hypotonia and respiratory or feeding difficulties. So the expanded repeat is transcribed into abnormal RNA that accumulates inside the nucleus, and this RNA sequesters muscle blind-like proteins, disrupting normal messenger RNA splicing in many tissues. Abnormal splicing of skeletal muscle chloride channel CLCN1 contributes to myotonia, and myotonia means delayed relaxation after voluntary contracture, not simply weakness. So a patient may have difficulty releasing a handshake or opening the hand after tightly gripping an object. Because the splicing abnormality affects multiple organs, the disease extends far beyond skeletal muscle. Patients may develop distal weakness, beginning in the foot dorsiflexors, followed later by hand and wrist weakness. Classic physiological findings include frontal balding, temporal wasting, a long or hatchet-shaped face, ptosis, and weakness of the facial neck muscles. Cataracts, testicular atrophy, and other endocrine abnormalities and cardiac conduction disease are also important. Cardiac conduction defects can cause sudden death, making cardiac monitoring essential here. So on an exam, the combination of grip myotonia, cataracts, and conduction abnormality should immediately suggest myotonic dystrophy. So some other muscular dystrophies here. So limb-girdle muscular dystrophy describes a genetically diverse group of disorders that primarily weaken the shoulder and pelvic girdles. Patients develop difficulty climbing stairs, rising from the chair, lifting the arms, or performing other activities that require proximal strength. Both autosomal dominant and autosomal recessive forms exist. Depending on the specific gene, the defective protein may participate in membrane repair, vesicle transport, cytoskeletal stability, or the dystrophin-associated complexes, so the age of onset and severity vary widely. Emery-Dreifuss muscular dystrophy is distinguished by early contractures combined with cardiac disease. Contractures commonly involve the elbows, ankles, and Achilles tendon and may appear before severe weakness develops. The X-linked form involves immurin, while autosomal dominant forms involve lamin AC. Both proteins support the nuclear envelope, so their loss makes muscle cell nuclei vulnerable to mechanical stress. Cardiac conduction abnormalities and potentially fatal arrhythmias are major concerns, and the exam pattern is early contractures plus conduction disease or arrhythmia. Facioscapulohumeral muscular dystrophy is an autosomal dominant disorder caused by inappropriate expression of the DUX4 or DUX4 in skeletal muscle. Weakness typically begins in the face and shoulder girdle, often by early adulthood. Patients may be unable to close their eyes tightly, whistle, or raise their arms normally, and scapular winging may be prominent and asymmetric. Weakness can later involve the lower trunk and foot dorsiflexors. The name itself provides the pattern: face, scapula, and humerus. Progression is generally slow, and life expectancy is usually normal. Congenital muscular dystrophies present at birth or in early infancy with hypotonia and weakness followed by progressive muscle degeneration. Ullrich congenital muscular dystrophy results from abnormalities in the genes encoding collagen 6. Collagen 6 helps organize the extracellular matrix surrounding muscle fibers, partly through its relationship with proteins such as perlecan. When this supportive matrix is disrupted, muscle fibers cannot tolerate mechanical stress normally. So the hallmark of Ullrich disease is unusual combination of proximal contractures and distal hyperextensibility. The hips, knees, elbows, spine may become stiff, while fingers, wrists, ankles, and other distal joints remain unusually flexible. So this mixed pattern is a powerful diagnostic clue in a hypotonic child. Myrosin deficient congenital muscular dystrophy is caused by deficiency of myrosin, also called laminin alpha 2. Myrosin helps attach muscle fibers to the extracellular matrix through the dystrophin-associated complex. Its loss destabilizes this connection, producing congenital hypotonia, delayed motor development, and progressive weakness. Alpha dystroglycan disorders result from defective glycosylation of alpha dystroglycan. Proper glycosylation is required for alpha dystroglycan to bind extracellular matrix proteins effectively. Because this protein is important in several organs, severe disorders may affect not only skeletal muscle but also the brain, the eyes. Thus, congenital muscle weakness accompanied by structural brain abnormalities, developmental impairment, seizures, or ocular disease should raise concern for an alpha dystroglycanopathy. So now some congenital myopathies, part 1. So central core disease is a congenital myopathy most commonly associated with RYR mutation and is often inherited in an autosomal dominant pattern. RYR1 encodes the skeletal muscle ryanodine receptor, the calcium release channel of the sarcoplasmic reticulum. Abnormal calcium handling impairs contraction and may cause hypotonia and weakness beginning in infancy. So orthopedic complications can include scoliosis and hip dislocation. Muscle biopsy shows central regions within the fibers that lack normal sarcomeric organization and mitochondria. These pale central zones are called cores. RYR1 mutations also increase susceptibility to malignant hypothermia, a life-threatening hypermetabolic reaction triggered by certain volatile anesthetics or succinylcholine. Uncontrolled calcium release produces muscle rigidity, rapidly increasing carbon dioxide, acidosis, hyperkalemia, and hyperthermia. And the triggering anesthetic must be stopped, and dantrolene is the specific treatment to this. So central core plus anesthetic plus anesthetic triggered rigidity or hypothermia strongly indicates an RYR1 disorder. Nurmaline myopathy is associated with abnormalities in thin filament proteins such as alpha-tryptomyosin 3, nebulin, or alpha-actin 1. It produces infantile hypotonia and weakness with widely variable severity, sometimes involving facial swallowing, or respiratory muscles. So biopsy demonstrates Nemaline rods, which are thread-like aggregates of Z-band material, and the name Nemaline comes from the word meaning thread. And so the essential recognition clue here is therefore rod-shaped Z-band inclusions in a patient with congenital hypotonia or slowly progressive weakness. All right, so when evaluating a congenital muscle disorder, begin by asking whether the muscle is being progressively destroyed, ongoing degeneration, regeneration, and replacement by fat or fibrosis pointing toward a congenital muscular dystrophy. Relatively stable or slowly progressive weakness associated with a distinctive structural biopsy abnormality points towards a congenital myopathy. Next, look for pattern-defining clues. Proximal contracture combined with unusually flexible distal joints suggest Ulrich. Congenital muscular dystrophy due to collagen 6 abnormality. Involvement of skeletal muscle, brain, and eye suggest alpha dystroglycan disorder because defective glycosylation disrupts extracellular matrix interactions in all three tissues. Biopsy finding can identify several congenital myopathies. Central cores combined with susceptibility to malignant hypothermia indicate central core disease, usually involving RYR1 or rod-shaped aggregates derived from Z-band material identify Nemaline myopathy. Numerous centrally positioned nuclei suggest centronuclear myopathy, a severe X-linked form. Historically called myotubular myopathy, is associated with the MTM1 gene and may cause profound neonatal weakness and respiratory failure. Congenital fiber type disproportion is diagnosed with when type 1 or slow twitch muscle fibers are consistently and significantly smaller than type 2 fibers without another defining structural abnormality. It typically presents with congenital hypotonia and weakness of variable severity. And so the overall strategy is to combine the time course with the distribution of the weakness, associated organ involvement, and the signature muscle biopsy finding. So spinal muscular atrophy, or SMA, is an autosomal recessive lower motor neuron disease, usually caused by the deletion or mutation of the SMN1. SMN proteins is involved in small nuclear ribonucleoprotein assembly, spliceosome formation, and RNA processing. So motor neurons are particularly vulnerable to reduced SMN protein. Their degradation in the anterior horns of the spinal cord produce denervation, weakness, hypotonia, muscular atrophy, reduced reflexes, and sometimes fasciculations. Sensory function is generally preserved because the primary injury involves motor neurons rather than sensory pathways. Disease severity is modified by SMN2, a backup gene that produces only a limited amount of full-length functional SMN protein because most of its transcripts are abnormally spliced. A greater number of SMN2 copies usually produces more functional protein and therefore a milder phenotype. SMA type 1, or Werding-Hoffmann syndrome, begins during infancy and causes profound hypotonia, weakness, feeding difficulty, and respiratory compromise. SMA type 2 has an intermediate course beginning in infancy or early childhood. SMA type 3, or Kugelberg-Wallander disease, begins later and is generally milder. These historical categories are useful, although modern treatment has substantially changed the expected course for many patients. Muscle biopsy shows grouped or zonal atrophy because entire motor units become denervated together. Surviving motor neurons may reinnervate nearby fibers, producing intermixed groups of normal or compensatory hypertrophied fibers. And so the classic exam presentation is a floppy infant with symmetric weakness, absent reflexes, preserved sensation, and grouped neurogenic muscular atrophy. All right, so NSAIDs or nonsteroidal anti-inflammatory drugs reduce pain, fever, and inflammation by inhibiting cyclooxygenase or COX. So this will then decrease the production of prostaglandins, prostacyclin, and thromboxane. COX-1 normally protects the gastric mucosa, supports renal perfusion, and makes platelet thromboxane. COX-2 is strongly involved in inflammation, but also has normal functions in the kidneys and vasculature. And this explains why blocking COX improves inflammatory pain, but can also injure the stomach and kidneys and cardiovascular system. Clinically, remember that NSAIDs are analgesic, antipyretic, and anti-inflammatory. They work best for prostaglandin-mediated pain and are much less useful for neuropathic pain. Their major risks can be remembered by checking the gut, kidney, heart, platelets, lungs, and pregnancy. They can cause dyspepsia, ulcers, GI bleeding, decreased renal perfusion, acute kidney injury, sodium and water retention, hypertension, edema, worsening heart failure, myocardial infarction, and stroke. Platelet inhibition increases bleeding, so while hypersensitivity may produce rash or bronchospasm. During pregnancy, NSAID exposure around week 20 or later can impair fetal renal function, and exposure around 30 weeks or later can prematurely close the ductus arteriosus. Most NSAIDs inhibit COX reversibly, but aspirin inhibits it irreversibly. So its platelets effects lasts for the life of the platelet. So COX-2 selective drugs reduce but don't eliminate GI injury and still carry renal and cardiovascular risks. So the safest general rule is the lowest effective dose for the shortest appropriate duration. So acetaminophen treats pain and fever but is not a nonsteroidal anti-inflammatory drug and has minimal anti-inflammatory activity but is still grouped because it helps relieve pain. All right, so for this drug table, okay, attach one memorable sentence to each drug, right? So aspirin sticks forever because it's it irreversibly inhibits COX and platelets, making it useful for cardiovascular prevention, but risky for bleeding, salicylate toxicity, and Rey syndrome in children with viral illness. Ibuprofen is common short-acting over-the-counter option, but it can interfere with low-dose aspirin antiplatelet effect. Naproxen is the longer-lasting cousin of ibuprofen and may have relatively lower cardiovascular risk than some NSAIDs, although the class risk still remains. Diclofenac is the local gel NSAID for focal osteoarthritis or musculoskeletal pain, but oral exposure carries notable cardiovascular and liver risks. Indomethacin is the exam drug for acute gout and closing of a patent ductus arteriosus, but it is relatively harsh on the GI tract and central nervous system. Ketorolac is a powerful short-term pain drug with a 5-day ceiling because of the major GI and renal toxicity. Oral therapy is only a continuation after IV or intramuscular dosing. Celecoxib selectively inhibits COX-2, so it causes less direct platelet inhibition and fewer GI ulcers, but renal and cardiovascular risks remain. Meloxicam only prefers COX-2 and is not truly selective. Remember it as a once daily arthritis drug that still carries the usual NSAID risks. And then acetaminophen treats pain and fever without meaningful anti-inflammatory or platelet effects. An overdose can cause hepatotoxicity, and the antidote is N-acetylcysteine. So gout begins when elevated urate permits monosodium urate crystals to form, although hyperuricemia by itself does not automatically mean the patient has gout, right? You got to find those crystals. So macrophages engulf deposited crystals and activate the NLRP3 inflammasome, leading to IL-1 beta release and intense neutrophil recruitment. So this creates a rapid onset red hot exquisitely painful monoarthritis, classically affecting your toe, and that is known as podagra. Repeated deposition can eventually cause tophi, chronic joint destruction, and uric acid kidney stones. And so treatment becomes much easier to remember when separated into treat the feelings or treat the crystals. So during an acute flare, the goal is to suppress inflammation quickly with an NSAID, colchicine, or glucocorticoid. An IL-1 inhibitor may be used in selected refractory cases, but these treatments relieve the current attack but do not lower the total urate burden. Long-term therapy treats the crystals by reducing serum urate. Allopurinol and febuxostat inhibit xanthine oxidase and decrease uric acid production. Probenecid increases renal urate excretion, while pegloticase enzymatically converts uric acid into a more soluble compound, allantoin, in severe refractory disease. And so these drugs prevent future attacks and gradually dissolve deposits, but they do not provide immediate pain relief. So starting urate-lowering therapy can temporarily mobilize crystals and provoke a flare. So colchicine, as well as a nonsteroidal anti-inflammatory drug or another anti-inflammatory, is commonly used as prophylaxis during the initiation. All right, so for gout pharmacology, first separate the flare drugs from urate-lowering drugs, right? So NSAIDs treat the inflammation of an acute flare by reducing prostaglandin synthesis, but remember that GI, renal, blood perfusion, heart rate, and cardiovascular risks, and do not use aspirin as the flare NSAID. So glucocorticoids are the broad anti-inflammatory backup when NSAIDs or colchicine are unsafe, but watch for hyperglycemia, hypertension, mood or sleep changes, fluid retention, and the possibility of septic arthritis before injecting a joint. Colchicine collapses the neutrophil railroad by binding tubulin and disrupting microtubules. It treats flares and prevents flares when urate-lowering therapy begins, but causes GI toxicity and can produce myopathy and rhabdomyolysis, especially with kidney and liver disease or CYP3A4 and P-glycoprotein interactions. Anakinra or canakinumab and rilonacept block IL-1 signaling in selected refractory disease, so with infection and injection reaction risks. Then you have allopurinol, which is the preferred first-line chronic drug and blocks xanthine oxidase. Start low, then titrate to the urate goal, and then use flare prophylaxis. Remember HLA-B58 associated hypersensitivity risk there, and avoid dangerous accumulation of azithromycin or mercaptopurine. Febuxostat is the non-purine xanthine oxidase inhibitor used as an alternative, but remember liver abnormalities, cardiovascular death concerns in patients with established cardiovascular disease, and the same contraindication with azithromycin or mercaptopurine. So probenecid pushes urate into the P by reducing tubular urate reabsorption, so it requires adequate kidney function and good hydration and can cause stones. Salicylates can blunt its effect. Pegloticase is IV recombinant uricase for severe refractory gout. It converts uric acid to allantoin, but may cause infusion reactions or anaphylaxis. So you can lose effectiveness through antibodies and is contraindicated in G6PD deficiency because of hemolysis and methemoglobinemia risk. All right, so rheumatoid arthritis is a chronic autoimmune disease in which persistent synovial inflammation gradually destroys joints. T cells, B cells, macrophages, and synovial fibroblasts release cytokines such as TNF-alpha, IL-6, IL-1, and the inflamed synovium proliferates into a pannus that invades cartilage, while rank L activates osteoclasts and creates bone erosions. So without disease-modifying treatment, this process leads to deformity and irreversible loss of function. Treatment, again, divides into treat the feelings versus treat the disease, and NSAIDs rapidly reduce pain and stiffness, while glucocorticoids rapidly suppress inflammation during the flare. Steroids may also serve as short-term bridge therapy while slower medications begin working, and these drugs can make the patient feel better today, but they do not adequately prevent progressive cartilage and bone destruction. Disease-modifying anti-rheumatic drugs, or DMARDs, suppress the underlying immune process. So methotrexate is the anchor conventional synthetic DMARD, while hydroxychloroquine, sulfasalazine, and leflunomide may be alternatives or combination partners. Biologic DMARDs target extracellular cytokines or specific immune cells, including TNF-alpha, IL-6, T cells, and B cells. Targeted synthetic DMARDs, such as oral JAK inhibitors, interrupt intracellular cytokine signaling. So these medications take time to work and require safety monitoring, but they are the treatments that preserve future joint structure. So the simplest memory line is that NSAIDs and steroids change today's symptoms, while DMARDs will change tomorrow's joints. And so here's your rapid fire rheumatoid arthritis drugs, right? So NSAIDs provide pain and stiffness relief without stopping joint destruction. Remember, GI injury, renal impairment, fluid retention, hypertension, and cardiovascular risk. Glucocorticoids are rapid bridge or flare drugs, but infection, osteoporosis, hyperglycemia, hypertension, and adrenal suppression make long-term use costly. Methotrexate is the weakly anchored DMARD that increases anti-inflammatory adenosine signaling. Give folic acid, monitor blood count, liver, and kidney function, and remember hepatotoxicity, myelosuppression, pneumonitis, and teratogenicity. Hydrochloroquinone is a milder DMARD whose signature toxicity is retinal damage, so remember eye screening and possible QT prolongation. Sulfasalazine is useful for mild to moderate rheumatoid arthritis or triple therapy. Remember GI upset, rash, CBC, and liver monitoring, folate supplementation, and hemolysis risk in G6PD deficiency. Leflunomide lowers pyrimidine synthesis and is a methotrexate alternative. Remember liver injury, myelosuppression, hypertension, teratogenicity, and its long half-life, which may require cholestyramine washout. The TNF alpha inhibitors are adalimumab, and etanercept, infliximab, certolizumab, and golimumab. Think block TNF, but unblock hidden infections. So screen for tuberculosis and often Hep B. Avoid live vaccines. And remember, serious infection, demyelinating disease, and heart failure caution. Abatacept is a CTLA-4 immunoglobulin that blocks T-cell co-stimulation. Remember, infection screening, vaccine review, and infusion or injection reactions. Rituximab depletes CD20 positive B cells. So remember, infusion reactions, Hep B reactivation, falling immunoglobulins, and rare progressive multifocal leukoencephalopathy. Tocilizumab and sarilumab block the IL-6 receptor. Remember, infections plus abnormalities in blood counts, liver enzymes, lipids, and possible GI perforation. Tofacitinib, baricitinib, and upadacitinib are oral JAK inhibitors that block intracellular JAK-STAT signaling. And all these guys are going to end in nib. Okay, and they all block different JAK receptors. Okay, so tofacitinib is going to block 1 and 3. Baricitinib is going to block 1 and 2. And then the upadacitinib is just going to block 1. All right, so at the normal neuromuscular junction, right, the motor neuron releases acetylcholine, which activates nicotinic receptors on skeletal muscle and produces depolarization and contraction. So acetylcholinesterase then breaks down acetylcholine and ends the signal. Every drug on the slide changes one part of the sequence. So neuromuscular blockers are going to turn skeletal muscle off for intubation, surgery, or selected ventilated patients. Non-depolarizing blockers competitively prevent acetylcholine from activating the nicotinic receptor. Succinylcholine does the opposite initially. It activates the receptor persistently, causing brief fasciculations, followed by depolarizing block and then flaccid paralysis. Either way, the patient becomes paralyzed until the drug wears off or is reversed. Acetylcholinesterase inhibitors turn the signal up by preventing acetylcholine breakdown at the neuromuscular junction, and they can improve myasthenia gravis or reverse selected non-depolarizing blockade. In the brain, certain agents can modestly improve symptoms in Alzheimer's disease. Too much acetylcholine, however, causes muscarinic, nicotinic, and central nervous system toxicity. Botulinum toxin relaxes selected muscles by blocking presynaptic acetylcholine release. Dantrolene acts inside skeletal muscle by inhibiting RYR1-mediated calcium release and treats malignant hypothermia. Neostigmine increases acetylcholine to compete against non-depolarizing blockers, while Sugammadex directly captures rocuronium or vecuronium, and it only works for those two. So just no Sugammadex for that. And then in organophosphate poisoning, atropine blocks muscarinic toxicity, and pralidoxime reactivates acetylcholinesterase before aging begins. And the critical safety rule is that paralysis does not produce sedation, pain control, or amnesia. A paralyzed patient can remain awake and aware. All right, so now for the rapid fire of the table here. So succinylcholine is the rapid depolarizing paralytic. It activates nicotinic receptors until the membrane cannot repolarize, and its memorable dangers are hyperkalemia, malignant hypothermia, bradycardia, and prolonged paralysis in bear with me now, butyryl cholinesterase deficiency, okay? There is no direct reversal drug, Okay, rocuronium is the rapid non-depolarizing alternative for intubation and can be reversed with sugammadex or after partial recovery an acetylcholinesterase inhibitor. Vicuronium is another non-depolarizing blocker used for surgical relaxation or selected ICU cases and shares the same reversal option. Pancuronium is the long-acting comparison drug that can cause tachycardia and prolonged blockade, especially with impaired renal elimination. Cistracurium is the organ-independent blocker, making it useful when liver or kidney function is poor. So reversal uses acetylcholinesterase inhibitor after partial recovery. Atracurium is similar but less favored because histamine release and the histamine release can cause problems. Right, so neostigmine raises acetylcholine to reverse partially recovered non-depolarizing blockade, but pair it with glycopyrrolate or atropine to limit muscarinic effects. Sugammadex selectively encapsulates rocuronium or vicuronium. It does not reverse succinylcholine, cistracurium, or atracurium. Dantrolene blocks RYR1 calcium release to treat malignant hypothermia with muscle weakness and hepatotoxicity as important adverse effects. Botulinum toxin cleaves snare proteins and blocks acetylcholine release for focal chemodenervation, but spread beyond the injection site can cause unwanted weakness or dysphagia. All right, so neostigmine is mainly peripheral and raises acetylcholine to reverse selected non-depolarizing neuromuscular blockade. It requires partial recovery, should be paired with glycopyrrolate or atropine, and will not reverse a phase 1 succinylcholine block. Pyridostigmine is mainly peripheral symptomatic drug for myasthenia gravis because more acetylcholine improves stimulation of the remaining functional receptors, so too much produces cholinergic toxicity, and it does not treat the underlying autoimmunity. Donepezil, rivastigmine, and galantamine enter the central nervous system and modestly increase cholinergic signaling in Alzheimer's disease. They provide symptomatic rather than disease-modifying benefit, and their major adverse effects are GI symptoms, bradycardia, dizziness, and syncope. Physostigmine also enters the brain and can reverse selected severe anticholinergic delirium, but avoid it when tricyclic antidepressant overdose or a cardiac conduction abnormality is suspected. Organophosphates phosphorylate acetylcholinesterase and cause profound acetylcholine accumulation throughout muscarinic, nicotinic, and central pathways. Respiratory failure is the major danger because patients can develop secretions and bronchospasm along with neuromuscular weakness. Atropine treats the muscarinic manifestations, especially secretions and bronchospasms, but does not reverse nicotinic paralysis. Pralidoxamine restores acetylcholinesterase activity and is especially important for weakness and paralysis, but it must be given early before the inhibited enzyme undergoes aging. The memory line here is simple. Atropine dries the patient, while pralidoxamine restores the enzyme there. All right. So autoimmunity begins when immune tolerance fails and the immune system recognizes self-tissue as dangerous. Sometimes a normal self-protein is chemically modified into looking like an antigen or a neoepitope. A key example in rheumatoid arthritis is the PAD-mediated conversion of arginine to citrulline. So tissue damage can also expose normally hidden antigens, while molecular mimicry allows an immune response against a microorganism to cross-react with similar self-antigen. Defects in regulatory pathways involving CTLA4, CD22, FAS and FAS ligand, complement-mediated clearance, or apoptosis further increase the risk that self-reactive lymphocytes will survive. So HLA alleles influence which antigens are presented on T cells, but an HLA association raises probability rather than confirming a diagnosis. Most autoimmune associations involve MHC class II molecules. HLA B27 associated ankylosing spondylitis is the most important MHC class I exception. The resulting injury depends on the immune effector. So Th1 and Th17 inflammation and CD8 positive cytotoxic T cell killing are type 4 hypersensitivity mechanisms. Antibody against cell surface or extracellular matrix targets produce type 2 injury, while deposited antigen antibody complexes produce type 3 injury. One disease can use several mechanisms simultaneously. Once injury begins, it can become self-perpetuating, and damaged tissues release more self-antigen, which activates more lymphocytes, antibodies, cytokines, and complement, causing still more damage. So CD4 T help through CD4 T cell help through CD4 ligand binding CD40 also allows B cells to class switch and undergo affinity maturation, producing a more potent and durable autoantibody response. So again, that little autoimmune slide was just kind of ushering us into the final part of this lecture, which is just going to be kind of like an autoimmune wrap-up. So there may be some repetition here, but I'm adding a little bit more sauce to it, okay? So with rheumatoid arthritis, it's, again, a progressive, usually symmetric inflammatory arthritis that commonly affects the small joints of the hand. Th1 and Th17 cells, macrophages, B cells, and autoantibodies maintain chronic synovial inflammation through cytokines such as TNF-alpha, IL-1, IL-6, and IL-17. Synovial fibroblasts release metalloproteinases that destroy cartilage, while rank L activates osteoclasts and produce bone erosion. Rheumatoid arthritis, therefore, involves a mixture of type 4 T-cell inflammation and type 3 immune complex injury and some type 2 antibody effects. Rheumatoid factor is usually an IgM antibody directed against the Fc portion of the patient's own IgG, and the resulting RF IgG immune complexes activate, complement, and contribute to a type 3 injury. So rheumatoid factor supports the diagnosis but is not specific to rheumatoid arthritis. Anti-CCP, also called ACPA, is more specific, and PAD enzymes convert arginine to citrulline, creating modified proteins that become neoantigens. Antibodies bind these citrulinated proteins, leading to opsonization, complement activation, additional tissue damage, and release of still more antigen, and this creates a chronic inflammatory loop. Ankylosing spondylitis primarily affects the axial skeleton and is strongly associated with HLA-B27, an MHC class I molecule. CD8 T cells, Th17 cells, natural killer cells, and gamma delta T cells may contribute, and chronic inflammation can eventually produce spinal fusion. Psoriatic arthritis often develops in patients with psoriasis and can affect both peripheral and axial joints. CD4 T cells, CD8 T cells, and B cells may all participate. And then the recognition shortcut is symmetric small joint disease for rheumatoid arthritis, inflammatory axial disease for ankylosing spondylitis, and arthritis occurring with psoriasis for psoriatic arthritis. All right, so polymyalgia rheumatica usually affects an older adult with aching and stiffness around the shoulders and hips. The key is that the pain and stiffness are more prominent than true muscle weakness. So Th1 and Th17 inflammation drives this process, and inflammatory markers such as CRP and ESR are typically elevated, and the muscle itself is not being destroyed in the same way as inflammatory myositis. So always screen a patient with polymyalgia rheumatica for associated giant cell arteriitis. Warning findings include a new temporal headache, scalp tenderness, jaw symptoms, a thickened or tender temporal artery, constitutional symptoms or visual changes, constitutional symptoms or visual changes. Sorry about that. And then you got visual symptoms are an emergency because vascular inflammation can cause permanent blindness, so glucocorticoid treatment should not be delayed when suspicion is high. Polymyositis, by comparison, produces true symmetric proximal muscle weakness over weeks to months. Patients struggle to climb stairs, rise from a chair, or lift their arms to comb their hair. Weakness is more prominent than pain. The skin is not involved, and creatinine kinase is elevated. Affected myofibers abnormally express high levels of MHC class I, allowing CD8 positive cytotoxic T cells to recognize self-antigens and directly destroy the fibers. Repeated destruction and regeneration then cause progressive weakness. Autoimmune myositis also includes dermatomyositis, immune-mediated necrotizing myopathy, anti-synthetase syndrome, and inclusion body myositis. Necrotizing forms often produce especially high CK creatine kinase levels, and statins are associated with some cases. Anti-Jo1 suggests anti-synthetase syndrome, classically combining myositis, interstitial lung disease, and arthritis. The most useful distinction is simple here, right? Pain and stiffness suggests PMR, or polymyalgia rheumatica, while objective symmetric proximal weakness with elevated CK suggests myositis. All right, so these diseases become easier to remember when you identify the cell being attacked. So in Sjögren's syndrome, Th1 and Th17 inflammation damages exocrine epithelial cells, reducing secretions throughout the body. Patients develop dry eyes and mouth and may also experience dryness of the nose, skin, throat, and vagina with impaired swallowing or digestion. The memory phrase is just dryness everywhere. In psoriasis, Th17-driven inflammation causes excessive keratinocyte proliferation, producing thick, well-demarcated plaques. Type 1 interferons from plasmacytoid dendritic cells amplify T-cell activation. Trauma can induce a new lesion at the injured site, known as Koebner phenomenon, and some patients develop psoriatic arthritis. Vitiligo occurs when CD8 positive cytotoxic T cells destroy melanocytes, producing sharply demarcated depigmented patches. Because the epidermis remains present, pigmentation may return if melanocyte killing is controlled and surviving cells can repopulate the area. Lichen planus results from CD8 T cell destruction of basal keratinocytes at the dermal-epidermal junction. This produces a dense interface, lymphocytic infiltrate and pruritic papules. Skin, oral mucosa, skin, and nails and hair may all be involved. Alopecia areata similarly involves cytotoxic lymphocyte and natural killer cell attacks, but the target is the hair follicle, producing smooth, patchy, non-scarring hair loss. The overall approach is to connect the target with the phenotype. Exocrine cells produce dryness. Keratinocytes produce plaque or papules. Melanocytes produce pigment. And hair follicles produce patchy alopecia, right? Melanocyte loss produces pigment loss, and then hair follicle produces patchy alopecia, right? All right, so the physical character of blisters reflect how deeply the skin separates. So pemphigus vulgaris is caused by IgG antibodies against desmoglein within the desmosomes, which normally connects neighboring keratinocytes. Loss of the cell-to-cell attachment causes acantholysis within the epidermis. So because only a thin layer covers the blister, it's fragile, flaccid, and easily ruptured. Painful oral involvement is common and may proceed to a skin disease. Direct immunofluorescence shows intracellular IgG in a net-like or fishnet pattern, and this is a type 2 hypersensitivity reaction and may become life-threatening through extensive barrier loss, infection, and fluid disturbances. Bullous pemphigoid targets hemidesmosomal proteins that attach the epidermis to the basement membrane, especially BP180, also called type 17 collagen, okay, and sometimes BP230. Separation occurs beneath the entire epidermis, leaving a thicker roof over the blister, and the resulting bulla are tense, often intensely pruritic, and may have a target-like appearance. Mucosal involvement is less prominent than in pemphigus vulgaris, but immunofluorescence classically demonstrates linear deposition along the basement membrane. IgG1 can activate complement. IgG4 can disrupt adhesion without fixing complement, and IgE can activate mast cells and recruit eosinophiles. So the exam shortcut is that pemphigus is superficial and flaccid with oral disease and fishnet IgG, whereas pemphigoid, okay, bullous pemphigoid, is deeper and tense with less mucosal involvement and linear basement membrane staining. And I just like to remember the bullous sounds bigger, so it's a little deeper, and so it's gonna affect those hemidesmosomal proteins. Okay. All right. Epidermolysis bullosa acquisita, what a name, is an acquired autoimmune blistering disease caused by antibodies against type 7 collagen. Type 7 collagen forms anchoring fibrils that secure the basement membrane to the underlying dermis. When those fibrils are disrupted, the epidermis separates from the dermis, producing a subepidermal blister. Skin and mucosal surfaces may both be affected. Complement activation recruits neutrophils, whose proteases damage the basement membrane zone further. Because the split is deep, the blisters may be tense, and healing can leave scarring or small keratin cysts called milia, especially at sites exposed to trauma. Scleroderma, or systemic sclerosis, is not primarily a blistering disorder. Its defining process is immune-mediated vascular injury followed by excessive fibroblast activation and collagen deposition. Antibodies against endothelial, fibroblast, and intracellular antigens accompany type 2 and type 3 immune injury, leading to inflammation, ischemia, and progressive fibrosis. The skin becomes thick, tight, waxy, or leather-like, and can restrict finger movement. Associated findings may include Raynaud's phenomenon. I have that. It sucks. Calcinosis and esophageal reflux. Anti-centromere antibodies are associated with limited cutaneous systemic sclerosis, remembered through the crest pattern of calcinosis, Raynaud phenomenon, esophageal dysfunction, and sclerodactyly and telangiectasia. The central concept is that vascular injury activates fibroblasts. Fibroblasts deposit too much collagen, and the collagen causes the characteristic hardening of the skin and internal organ fibrosis. All right, so dermatitis herpetiformis is the cutaneous manifestation of celiac disease. So IgA antibodies associated with gluten-sensitive disease react with transglutamase in the skin, and complement activation and neutrophil recruitment then produce an intensely pruritic grouped rash, classically on the extensor surface. Despite its name, the disorder is unrelated to herpes infection. Direct immunofluorescence demonstrates granular IgA deposition at the tips of the dermal papillae. Systemic lupus erythematosus demonstrates how circulating immune complexes can injure multiple organs. So antigen-antibody complexes deposit in tissues and activate complement, creating a type 3 hypersensitivity reaction. In musculoskeletal and integumentary systems, this can produce inflammatory joint symptoms and characteristic skin disease, including a malar rash. So multiple sclerosis and Guillain-Barré or Barré syndrome may both cause weakness, but the primary immune target is neurologic rather than skeletal muscle. So multiple sclerosis affects central nervous system myelin, while Guillain-Barré affects peripheral nerves or nerve roots. And the weakness results from impaired nerve conduction rather than primary destruction of the myofibers. Autoimmune treatment can interrupt lymphocyte activation, IL-12 dependent proliferation, leukocyte adhesion and extravasation, IL-12 and 23 signaling, or inflammatory cytokines such as TNF, IL-1, and IL-17. The unavoidable trade-off is that suppressing harmful autoimmunity also weakens protective immunity, right? So increasing susceptibility to infection and sometimes malignancy. And that's why it's always so important that if you're using a TNF alpha inhibitor, an IL-6 receptor inhibitor, or an IL-1, right, you must screen for tuberculosis, Hep B. It's pretty much, right, you're down-regulating this person's entire immune system. So you want to make sure you're not going to kill them by basically destroying their immune system as a treatment. So here's like the rapid review slide again. So just 5 things to lock in real quick. So here are 5 associations to make it automatic. So papules with dense lymphocytic infiltrate along the dermal-epidermal junction indicate lichen planus, where CD8 positive cytotoxic T cells attack basal keratinocytes. Symmetric proximal weakness with an elevated creatine kinase indicates polymyositis, where CD8 T cells attack myofibers that abnormally express high levels of MHC class 1. Painful oral lesions combined with fragile intraepidermal blisters and fishnet IgG staining indicate pemphigus vulgaris caused by antibodies against desmoglein. A malar rash associated with immune complex deposition indicates systemic lupus erythematosus and type 3 hypersensitivity mechanism. Finally, rheumatoid arthritis. Autoantigens are created when PAD enzymes convert arginine residues to citrulline, allowing anti-CCP antibodies to recognize the resulting modified proteins. And so the common strategy is to connect the clinical clue to the immune target and then to the hypersensitivity mechanism. Right, so JIA, or juvenile idiopathic arthritis, is an inflammatory arthritis that begins before the age of 16, persists for at least 6 weeks, and has no better alternative explanation. So the subtype is determined by the pattern that is present during the first 6 months. Because there's no single diagnostic blood test, JIA remains a clinical diagnosis of exclusion. So the evaluation begins by counting involved joints and confirming objective inflammation through swelling, warmth, stiffness, restricted motion, or painful limitation, right? So next, look for systemic findings such as fever, rash, lymphadenopathy, or splenomegaly. Psoriasis and inflammation at tendon or ligament insertions can point towards specific subtypes. So infections, malignancy, trauma, reactive arthritis, and other connective tissue diseases must be considered before labeling the condition as JIA. Laboratory tests provide supporting information rather than making the diagnosis. So ANA positivity predicts a higher risk of uveitis, particularly in young girls, but it does not prove JIA. Rheumatoid factor separates rheumatoid factor positive from rheumatoid factor negative polyarticular disease, while ESR and CRP estimate inflammatory activity. Normal blood counts, normal early radiographs, or surprisingly little pain do not exclude the diagnosis, but chronic anterior uveitis may be asymptomatic, which is why scheduled ophthalmologic screening is essential here. So the case anchor is a 4-year-old girl with swelling of the knee and both ankles for 6 weeks, positive ANA, negative RF, elevated CRP, and no fever. 3 involved joints during the first 6 months indicate oligoarticular JIA, and her age, sex, and ANA positivity place her at particularly high risk for silent uveitis. All right, so now getting into the subtypes. So oligoarticular JIA is the most common subtype and involves 1 to 4 joints during the first 6 months. It peaks between ages 2 and 4, strongly favors girls, and has the highest uveitis risk, especially in young ANA positive girls. So few joints, but high eye risk is the memory line for oligoarticular JIA. Polyarticular RF negative JIA involves at least 5 joints and has peaks around ages 2 to 4 and 9 to 11. It is more common in girls, can involve large or axial joints, and carries an intermediate uveitis risk. Polyarticular RF positive disease also affects at least 5 joints but tends to present in adolescent girls, behaves more like adult rheumatoid arthritis, and causes relatively aggressive joint disease with lower uveitis risk. Systemic JIA can occur at any childhood age and affects girls and boys similarly. It combines arthritis with high spiking fevers and transient salmon pink rash. Lymphadenopathy and splenomegaly may occur while uveitis risk is low. Think fever and rash, not primarily eye disease. Psoriatic JIA combines arthritis with psoriasis, although the rash is present in only about half of the patients at presentation. It peaks in early childhood and again around the ages of 9 to 11 and carries an intermediate uveitis risk. So enthesitis related arthritis usually affects boys aged 11 or older. Its defining feature is inflammation where tendons or ligaments insert to the bone, often accompanied by lower extremity or axial arthritis. It represents the childhood end of spondyloarthritis spectrum and also an intermediate uveitis risk. Undifferentiated JIA is used when the presentation does not fully meet one subtype's criteria or overlaps multiple categories. So the fastest way to organize the 7 groups is by joint number, RF status, systemic fever and rash, psoriasis, and whether the patient fits cleanly into one category. Right, so the goal of JIA treatment is not simply to make the child feel better. It is to suppress inflammation, and before permanent joint damage or abnormal growth occurs. So similar to just, rheumatoid arthritis. So NSAIDs similarly can provide initial relief of pain, stiffness, and inflammation, but they do not reliably control progressive disease by themselves. Corticosteroids provide faster anti-inflammatory control and may be given systemically or injected directly into the affected joint. Because prolonged systemic steroid exposure can interfere with growth and bone health, the aim is generally to limit its duration. Methotrexate is a major disease-modifying therapy when arthritis remains active or involves multiple joints. Biologic therapy may be added for more severe or resistant disease. Anakinra blocks IL-1, while tocilizumab blocks IL-6 signaling. Both are especially important for systemic JIA, where these cytokines drive fever and systemic inflammation. Poorly controlled inflammation can cause progressive cartilage and bone destruction, short stature, osteopenia, osteoporosis, temporomandibular joint disease, or unequal leg growth when inflammation affects growth plates asymmetrically. Uveitis is one of the most important complications because it can remain silent until the eye damage has occurred, making scheduled ophthalmologic screenings essential. The central message is that early control protects not only today's comfort, but the child's future joints, vision, growth, and function. Finally, a rapid review. So juvenile idiopathic arthritis is a clinical diagnosis requiring arthritis that begins before the age of 16, persistent for at least 6 weeks, and has no better explanation. Arthritis lasting less than 6 weeks cannot yet be classified as JIA. Laboratory tests support the diagnosis and help with subtyping for these risk predictions, but no laboratory result independently confirms or excludes the disease. Do not expect every child to report severe pain. Persistent swelling, warmth, morning stiffness, restricted motion, or altered use of a limb may reveal significant inflammation despite surprisingly little discomfort. Normal white blood cell counts, normal early radiographs, or failure to improve with antibiotics should not distract from chronic inflammatory arthritis when the clinical pattern fits. A young ANA-positive girl with oligoarticular disease has the highest risk of silent uveitis and requires regular eye screenings. High spiking fevers and a transient salmon pink rash, lymphadenopathy, or splenomegaly suggests systemic JIA. An older boy with inflammation where tendons or ligaments insert into bone suggests enthesitis-related arthritis. And then an adolescent girl with RF-positive polyarticular disease is more likely to have an aggressive adult rheumatoid arthritis-like course. And the best exam strategy is to just recognize the age, the sex, the number of joints involved, systemic feature, and then psoriasis or enthesitis, and then RF status, and then uveitis risk. All right, thank you as always for clicking on the vid. Hope this was good for just a quick review, whether you're listening to this in the car, at the gym, wherever. I hope it helps. I hope it helps you net some points, 1 or 2 at least, on the next exam. As always, thank you as always for stopping by Moose Med, where we take medicine by the horns, but for all intents and purposes, moose have antlers. Thank you as always, folks. See you next time.